Should be through by 6, don't you?
Get a second half.
That might be all you want to see.
Thank you.
Is it? Yeah. As long as I don't start swearing and uttering.
Did I hear that? No.
I just picked up that we've got Trevor on Teams and,
Yeah.
and Simon Fogel.
Yeah, so I know, yeah. Thank you. Alison, is the reason why that's inverted on the screen?
Yeah, I don't know actually. That's weird, it wasn't like that before.
It's just...
By not doing something or by doing the wrong thing.
Probably a bit of both. Let me have a look, but it's just.
I turned it down. And it was like they ran on the Thursday to a Saturday, and I wasn't like, you've got lots of stuff in place. Then, yeah, at least she said it's next
You're not
Wednesday.
turning it down now, though,
No,
because you'll give it So what, you're not replacing it?
It'll change when Trevor logs on.
All right, okay.
You can change it, but it goes into wide shot, and then we see everybody sitting in the room, which I said we don't want to see.
Good afternoon, everyone. I hope you can all hear me. Welcome to this meeting of our Integrated Care Board. Good to see you all. I was slightly unnerved a moment ago when I noticed that the screen in front, the wording was inverted, and that might not be catastrophic, but then there are two of our members who are coming into this meeting via Teams, and I wondered how that inversion might affect their appearance. But I gather it's a minor issue and will be satisfactorily resolved. Let's start straight into the agenda, if I may. A few apologies. Jacqueline Small, Neil Carr, Stacey Keegan, Paul Watling, Sean Davis, Nitty Paul, and Kathy Pert. For the vast majority of those people, at least, we have deputies, and a welcome to them. People dialing in, Trevor Macmillan and Simon Fogel. Somebody will need to nudge me, probably Simon, if they're trying to contribute to the discussions and I can't see them or miss them, but I'm sure we'll be able to manage that reasonably well. I just wanted to start this meeting and acknowledge the intense sadness relating to the deaths of 4 teenagers residents in Shrewsbury, Shropshire. Jevin Alexander, Harvey Owen, Rilford Fitchett and Hugo Morris were looking forward to their lives and had every reason to feel optimistic from the little I've known, and that's by reading, that they had great futures ahead of them. What a tragedy. And I simply wanted us to recognise in this meeting that sense and sympathy for the families of those lads. And I'm not quite sure how we will make sure that the families, that we're thinking of them, but we will find a way of doing just that. So I hope you don't mind me raising that. It's an incredibly sad turn of events. Some further announcements, if I may. Finally, the world's worst kept secret Simon has been appointed our Chief Executive. Sounds like I've been announcing this in other meetings for some time now, but this is the first. He's nodding his head frantically. But I announce it again because if it's in the HSJ, then it must be true. So well done, Simon. We're delighted that you've been appointed. And also, I wanted to acknowledge the appointment of Jacqueline Small as the new chair of MPUFT. As I said earlier, Jacqueline can't be with us today. I think she's got a family bereavement that she is attending to, but I'm really pleased, and I'm sure you're all delighted as well that she has been appointed too. I also wanted to recognise Alison Bussey, who, I think, Alison, this is probably your last board meeting. Alison joined us at the start of the journey of the ICB, not too long over a year or so ago, 18 months or so ago, I imagine. Alison is retiring, and I just wanted to acknowledge, Alison, the great work you've done for us, particularly in the formative years, months of our ICB, and wish you the very best for the future. And linked to that, I simply want to announce that on an interim basis, Vanessa Watley, who is well known to many of you. Is Vanessa here today? I don't see her. Vanessa's been a regular attender in these meetings anyway. Vanessa will be the interim Chief Nursing Officer for the foreseeable future. That's a great appointment. We're lucky to have Vanessa working with us already, and we look forward to seeing her around this table. As we move into this agenda, I suppose there could be a temptation that we delve into the detail of many of the challenges that we face. If we think about winter and our overall performance, which we know is not where it ought to be, where we'd like to see it, and in particular when you think about, and we learn more about our financial position later, we could spend, frankly, the whole of the rest of the meeting just thinking about those issues. And we will give them proper attention at the appropriate time during the meeting. But suffice to say, I know that all organisations are working incredibly hard to try and make sure we have a plan crafted and agreed to enable us to have a safer passage through winter as possible. And equally importantly, people are working really hard together to find ways of beginning to, I suppose, change the course of our financial position so that no less than moving into the new financial year, we're beginning to show signs of improvement. And that's a big ask. We've got some big challenges. And there's a huge amount of discussion taking place behind the scenes about our financial position, including a confidential Part 2 meeting of the board last Monday, where we looked into this in some detail, organisation by organisation. So I don't want you to feel constrained in terms of your comments, your questions and your challenges, but forgive me if I don't encourage a detailed discussion about lots of different aspects of either performance or finance. We will receive reports, and you will get an opportunity to comment and ask some questions if you'd like to. Because there are lots of other things that we need to address which are very important and on the agenda for today. Declaration of interest. I've not been notified of any changes, so I assume the Declaration of Interests is, as currently written, is extant. And if I'm right about that, I'd like to take this into the minutes of the previous meeting, held on the 27th of September, and ask you whether you're happy with their accuracy. Mike.
Just one very minor point, 106.3, which is on page 4, which relates to the CQC inpatient survey. We're listed here as being the #1 specialist trust. It was actually out of all organisations, not just specialist organisations.
Thank you very much indeed. Mike, your chair will feel you've earned your corn, drawing that to our attention. A great achievement, whether it's for specialist hospitals or not. If it's for all hospitals, then that's really good news. Well done, well done. Any other points of accuracy that people wish to raise from the minutes? If we look at the action list, there are 2 or 3 things that I've pulled out, and I think there's one action that's missing, and I haven't actually double-checked this with the minutes, so forgive me, I'll come to that in a moment. We said in the action list we'd have a note about HTP. Actually, we've got, better than a note, we've got Matthew Neal making, I think, a presentation to us later. And as part of that, we will talk about the process that we as a board need to enjoin in terms of signing off the full business case, but we'll come to that later. There was a challenge from, I think it was Harry, about, I'm paraphrasing, how come the numbers of GPs have increased but the numbers of appointments have reduced? It was something along those lines. And I think, Claire, you said you were going to try and find ways of looking into that. Have you been able to do that?
We've got some data back, but the team are just in the process of testing that with the primary care team to make sure that we've got the correct response. But if you're content, I'll circulate that as just a briefing note afterwards.
Okay. Thank you very much indeed. You okay with that, Harry?
Yes, absolutely.
Yeah. The other one I just wanted to pull out was MSK. We'd talked about that at the board development session. I know there's a huge amount of discussion taking place about how to take that forward. Mike, you must get this all the time. I do apologise. Would you like to just bring us up to date with where you've got to, where we've got to with that new arrangement?
Yeah, absolutely. So, significant amount of work that's been going on. We've had large clinical engagement events with clinical colleagues from across the partner organisations in attendance there and contributing to those discussions. We presented some of the high-level work streams that we have at the board development session last month, and we plan to do a detailed update on the programme at the next integrated delivery committee, with a view to then that being the next step before a fuller update on MSK returning to this board. A high level, we've really broadened out the scope of the MSK programme, so not just looking at the triage and interface service, but continuing that focus, looking at rheumatology as a specific service and what we can do there, orthopaedics and the optimisation of orthopaedics across the system as well, and the integration with primary care, and also the work that we're doing around digital. And there's been some really positive movements very recently in terms of applications that we've made for digital funding to the tune of nearly £500,000 or so to support MSK in this system, which we've been successful in. So all of that will come back to the Integrated Delivery Committee in December, and then if it's allowable, if we can have a dedicated slot on this board in January, it'd be really appreciated.
I think we're all agreed at the board development session, it's such an important issue, and it's an important issue because it will demonstrate to us all about how collaboration can work in practice, and hopefully will set the tone for future work. So I think we'd probably all agree that we'd give you a slot, all of the interested parties, to discuss this further in January. The one thing that's not on the action list, which I think probably ought to be, when we talked about the digital strategy at the last meeting, I think we said, all very interesting, thank you very much indeed, but what happens next? And we asked for a piece of work to be taken forward to show the next steps and actions. I just wanted to put that on the action list because I think that's very important. And Nick, I don't know what kind of a timeline you might have had in mind for that. Do you want to give it?
Board will be in 2 months' time.
In January, yeah.
We'll try for January, but I'm just conscious we've got Christmas.
Well, maybe you
away.
could give us an update.
We'll give you an update. So, a work programme is being developed, and it's known as a roadmap in digital parlance, and this should be able to present it either at the next board or the board after that.
Thank you.
I was just going to add that I'm working very closely with Nick on this, and we wanted to, we've also committed to give an overview of that plan of action at the strategy committee in early Jan, so which is useful because it aligns then with the delivery against the digital strategy. Yeah,
that's helpful actually. It would be good to have the strategy committee's take on the next steps prior to it coming to this full board. That's really good. Thank you very much indeed.
And Neil, if I can just add, we're making really good work. Mike's alluded to it. So we've been successful with 5 bids for national money for artificial intelligence, 3 of which are around supporting MSK. So we are making progress, and we are bringing increased digital maturity into the system.
Excellent. Thank you. Good news. Well done. Are there any other matters arising, any other actions that I've not referenced that people wish to pick up? Mr. Sidaway.
Thank you, Chair. It's the second row down on page 27. Just checking in really, the one that's been allocated to Gareth, Ian and Nick in terms of the engagement with both councils. Has that taken place? Is my just general question. It's not loaded, I haven't checked. I just want to make sure because I haven't heard any feedback from it, that's all. Thank you, Chair.
Gareth, did you want to?
Just check, remind me of the context there, sorry, I can't remember my page.
It's related to the recovery plans on page 27 of the pack.
I can't find mine at the moment either.
Recovery plans in the...
So it's the GP recovery plans. It was socialised at the last board meeting, and then it was to be, the work was to take place with those local authorities before we got to the formal update today.
Just bear with me while I get my head into the right place. So the access recovery plans have been to the Joint Health Oversight Scrutiny Committee. I think, David, I'm struggling with my memory. Can I confirm that outside?
Let's take it.
Chair,
let's take it up outside of the meeting
request...
and be clear about what the ask was. And could you organise some kind of information note for the board that we can append to the minutes or something like that to satisfy?
Chair, Neil, people in the audience are really struggling to hear. So can I request that everyone speaks into the microphone so people can hear?
Does that include me? I don't mind speaking into the microphones. The question was, can you not hear me either? Because that's not usually a problem I have. Okay, thank you. Thank you very much indeed, David. We'll try. If you can't hear us, just raise your hands and we'll try and improve. Thank you, Edna. Okay. Moving on, the next item is questions from members of the public. We haven't had any new questions since the last meeting, but there's a whole schedule of previous questions and answers appended to your board papers, which I hope the people who raised the questions are satisfied with. But if there are any other points that board members wish to raise, then please feel free. Everybody content with those as they are written? Yeah. Okay, let's move into the next item on the agenda, patient story, Armed Forces Covenant. Some of us have been involved, all NHS organisations, the two local authorities and others have been involved in a signing event for the Armed Forces Covenant for the ICB, which is, as it were, supersedes that which was signed by the CCG in 2021. So the ICB is catching up in that respect. So some of us are pretty well versed in the essence of the covenant arrangements at the moment. And I don't know, Gareth, what you're going to be telling us about, but I'm intrigued and interested. Over to you.
Well, we actually have a video prepared.
A video, okay.
Can I just check that the microphone's working? Can you hit? Great, thank you. So as you've described, Chair, this month's resident story has a veteran focus. Sarah Kerr, who is our Shropshire Armed Forces Outreach Support Coordinator, talks about our veteran community in the county, and the barriers for people identifying themselves as a veteran and the benefits of GP practices becoming more veteran friendly. We also get the privilege to hear from Bob Adams, a 90-year-old Korean War veteran, and his wife Sue, who both live in Shifnal. And at this point, I'm hoping that the video will work.
So I'm a veteran. I served 10 years as an army nurse, and then for another 25 years I supported my husband in his career, so he's also a veteran. So I've been in and around the military for over 35 years. So the census that happened in 2021 was the first time that the veteran question was asked, and from that we've identified that in Shropshire Local Authority there are 14,800 veterans, and then in Telford and Wrekin there are another 7,000 plus. So nearly 22,000 veterans alone in Shropshire. And then we've got the 3 military bases as well. So we've got RAF Shawbury, RAF Cosford and 1 Royal Irish at Turnhill. And again, a large number of service personnel and their families living there. The military community, veterans all serving, they're very stoical, very proud people, won't always admit that they need help and support. and sometimes by the time they do ask for that help, whereas it could have started off with just one issue that they needed support for, those issues have grown and multiplied. The GP practice accreditation scheme is to better identify, treat and refer an individual or a family member for the support they need using the NHS services. So that can be mental health. You've got Op Courage, which is the Veterans NHS Mental Health Service. Here in Shropshire, we're lucky enough to have the Robert Jones Agnes Hunt Hospital, who has their own veterans service for the orthopaedic side of life. So it's about the GP being able to identify what help and support is out there for that individual by knowing that they are a veteran. It could be also that actually somebody is a widow or a spouse of a veteran, and again identifying if there's any help and support for them. We're also lucky enough in Shropshire to have the social prescribers, and I look at my role very much as a social prescribing role, but within the GP practice it might not be a clinical issue that that individual needs, but it could be that they're socially isolated or they're needing some adaptations in their house and bits and pieces that the social prescribers may pick up on, and that's where the referrals can be made to the relevant organisations. I think it's really important. I think it makes the veterans feel that they're being listened to. You know, as we see over the years, there's been lots of different campaigns. So there's a lot of veterans out there struggling, and I think to just identify themselves as they book in, register, just means that actually, if that's annotated on their notes, when they're starting to talk about something, hopefully the GP or the other staff members within the GP practice will appreciate that there is a need for them to talk and understand where they can be signposted to.
I served at Shrewsbury Barracks, Copthorne, for 6 weeks. And then 8 of us out of the old raft went to Stransell. We didn't do a lot of training there because they didn't know what to do with 8. But we ended up at Robin Hood Bay in Yorkshire, at the Ordnance Depot. But they called us back when the draft of Durham lads had done their training, and we got put in with them and sent to Korea. And we stopped in Hong Kong till we were 19, and then we went to Japan, dropped off there, or some got dropped off in Korea, the older ones, and we came back. After 10 days, we came back to Korea, and we stopped at Busan overnight. The next day we were catching a train to go north. We had 7 injections, and 3 in one arm, 2 in the others, and 2 in the bum. And I'd never been more than New Brighton, that's it. Went there on a choir trip, and the other time I'd been with Mother to Brisnorth, which was 6 miles. That's as far as I'd ever been from home. And we ended up in Korea. It's quite an experience. And we got put into the Commonwealth Division. And we fought with the Australians and New Zealanders. And we came back out. The last day we came out, we had to go back in because the Americans had pulled out and left the Australians exposed. And we had to go back into the line with the 2nd Battalion Australia, cover them. We had 12 months out of them.
We had to fill the form in, and there was a questionnaire about being a veteran. And when we handed it in, the receptionist said someone will be in touch with you about it. And a few weeks afterwards, the veterans coordinator from the practice rang and chatted to Bob. They seem to, you know, sort of be very interested in the fact that you're a veteran and, yeah. Because I do think it probably does have, those sort of times does have an effect on, I mean, he's riddled with arthritis, and I'm sure that probably, yes, he's worked outdoors all his life, but I'm sure those conditions probably didn't help.
Well, I could change my socks and shoes and
Yeah.
clothes, and,
Yeah.
but there you couldn't.
Yeah.
You lived in them, like, was it?
Yeah, so I think perhaps it does have an effect. And if not, it probably does with some people, particularly probably mental health, I would say.
You lost your mates and that was it, really. They just either went down to Busan or they came home.
Is that the conclusion?
That's the conclusion. That is the conclusion.
Did you want to say anything more?
No, I think it's, I mean, today's a significant reminder of the role that Armed Forces has to play in our local health community. We'll come on to some other issues that, as part of the Chief Executive report and our obligations to our people that have contributed to our country in many different ways. And I think it was a very powerful, evocative story on that basis.
Julian, Ian, anything you want to say about that which you've heard?
Thank you for the video. I think the Armed Forces veteran accreditation is very important for primary care. I don't know the numbers off the top of my head, but I do know a lot of practices in Shropshire already have veteran accreditation, but not all the practices. Certainly in my practice in Ponsbury and Worthing, we were one of the first to become in Shropshire a veteran-friendly accredited practice. I think it is really important, and it's changed the way we approach things. We ask people on their new patient registration about veteran status, and that can either be, I think you have to have served a minimum of a day in the armed forces to be counted as a veteran. So it has made a big impact, and our staff go to regular training about that. And I think also it's much broader than that as well, because it's about the Armed Forces Covenant, which I think a lot of organisations in Shropshire, Telford and Wrekin have signed up to. I think, if my glasses are right, is that Karen Calder next, David? Yes. I think back before in the CCG was with you, wasn't it, that the CCG signed up to the Armed Forces Covenant, and I'm not quite sure what the status is currently of the ICB, but obviously that's a much broader way of recognising the support that the armed forces need, and also people who've been in the armed forces and supporting them across a variety of things. I'm sure people could do more, but I think it is important that as organisations we do try and commit to the Armed Forces Covenant.
And Simon and I signed the covenant on behalf of the ICB just before this meeting, and that supersedes now the former CCG commitment. So we're committed. That's formalised, which is an important statement of intent, really. And as Gareth said, we perhaps Simon pick up other aspects of this when we get to your report. Any other questions? I mean, they seem as if they're very satisfied the responsiveness that primary care has offered. I have no idea, I wonder if you guys do, whether if we were to talk to others who with other practices we'd get the same kind of responses, do you think?
Mostly, I think most practices have signed up for this already. And because locally there are pathways specifically for this, for referral, so it's worked well.
I'm just peering with Health Watch. A Health Watch in the room? Aha!
Hi, I'm here in place of Lynn Corley today.
So is it, sorry to put you on the spot as it were, is this something that crosses your desk, as it were, this kind of issue as Health Watch?
We have been along to many veterans' coffee mornings and things to talk to people, but it's not an issue that we've heard about particularly to do with GP support and access. It's more to do with the services that they're then referred on to, perhaps, so mental health support and other, more of those social issues that are perhaps not as catered to as well.
Okay, thank you. And Pauline, if you don't mind, as the MPUFT representative, we heard about the importance of mental health and armed forces veterans, etc. And anything you want to tell us about the MPUFT approach to this issue?
You're definitely putting me on the spot there, Neil. What I would say is we're very committed to supporting veterans, and it is actively thought about at board.
Okay, thank you very much indeed. Julian.
It would be remiss to move on from the staff giving Harry and Mike the chance to talk about the wonderful centre that's at Robert Jones and the new building there, because I mean that's a tremendous facility and very recently opened and has utilised resources that are being moved from elsewhere within charities that support the armed forces. So I think we ought to hear a little bit about that, I think.
Yeah, who would like to say something about that? Harry?
I can start. I mean, the centre, as you know, was built as a result of a gift from the Headley Court charity, which was the centre down in the south that looked after Afghan veterans at the time. They gifted us, I think it was £6 million to construct it. It's very much a treatment centre, so minor treatments, that sort of thing, and it's also used for recruitment. There's a veterans, there's a permanent veterans, Shropshire funded veterans place there. It's stage one of a 4-stage project that we're just working up now. I don't know what order stage 2, 3 and 4 will be, but there'll be a gym, a residential area, and then a sort of a lounge sort of discharge area. And I think I mentioned at a board meeting probably 2 meetings ago that we felt we were very close to an arrangement with the Headley Court charity in terms of any legacy as they wind their charity up. And we haven't quite concluded that yet, but conversations are going well. Once we've got that concluded, there will be a fundraising campaign to raise funds for stage 2, 3 and 4.
Thank you very much indeed. Meredith, did you want to come in? You've got a red light shining, showing, and I'm never sure what that means, but if you'd like to speak, feel free.
Thank you. It hadn't been my intention. I was just musing over the response to your question about would others recognise this, what we've heard in the film. Actually, I really don't want to create industry for people, but I did wonder whether it would be possible to look through patient feedback across the system that we might have had with a kind of a focus search on veterans' experiences, just to get a sense of it, because one experience is interesting, but it's not an evidence base. So whether it might be possible just to do a bit of digging and reassure ourselves, I suppose, that we are picking up thematic information for veterans.
Simon and I are just musing as you speak, Meredith, because I think you raised an important point. I wonder whether it might be possible to enlist the help of Health Watch in a piece of work around this. We'd have to be conscious of access to patient records and all of that, but I wonder if it might be possible to do that. I wonder if we can pick that up outside of the meeting, if that's all right. Okay, look, this is the second conversation we've had, I've been involved with on this important topic today, and we've got more to come this afternoon. What's really important is that we make sure our fine words, sentiments and ambitions become something like the reality that veterans deserve. I'm sure we do pretty well already, and I just want us to make sure that we keep this on the radar during the life of an ICB and review this from time to time and ask ourselves the question that Meredith very pertinently begged about how we think we're doing. More importantly, how do veterans, their families, reservists, etc. feel that we're doing. So let's clock that, and we'll come to more of that with Simon's report in a moment or two, which is the next agenda item. Simon.
Thanks, Chair. So I will work on the principle that the paper is as drafted and as read, and people are aware of that. A couple of bits to pull out, but before I dive into the detail of it, I wonder if it's just worth updating the board, and this happened quickly, and so it's not, in terms of the production of papers, it didn't make it into the drafting of the paper, but I just wondered, Gareth, if you wanted to update on Operation Lazarite and the response in terms of system partners to that, and explain what it is, please.
Yeah, sure. So Operation Lazarite, I'm incredibly conscious that I think broadly a Shropshire Council-led response in terms of the overall issue is Shropshire, Telford and Wrekin has been identified as a potential location for previous refugees from Afghanistan who have been cared for, looked after in Pakistan, are being repatriated back to the UK at a significant pace. So on Monday or Tuesday last week, we were informed we would be receiving 250 citizens into the Nestcliff training camp. 258, as we understand, have arrived this morning. I can't confirm that it is exactly 258, but we certainly expected it to be. Predominantly under 19, so there's 150 under 19 citizens who are requiring housing and the integration into the UK. They are using Nestcliff as a staging post, for want of a better term, while they are provided with housing and all of the support facilities that they require. We're in the midst of setting up the health services and all of the supporting infrastructure that they need to successfully integrate within the country. It is difficult, it is really challenging. All colleagues from all parts of the system are contributing really heavily across the housing, education and health service. So as it stands, there are still some operational issues to resolve, but the board can be clear that the operational response from all partners is caring well for those citizens.
Thank you. And Andy, before I hand back to Simon, is there anything you want to add? Okay, thank you.
So just on that, the final bit for me, Gareth touched on it, is just to say thank you. I would ask Chief Exec, Chair colleagues, local authority, as well as NHS and to general practice colleagues, because the speed of mobilisation and support and the collaborative team working has been fantastic. So I'd just be grateful if people could pass on that thanks on behalf of the board back to colleagues around that, please. The paper then sets out a number of areas of core business. It highlights the pause in industrial action, which is welcomed as ever. I take the opportunity to encourage all parties involved to reach a settlement as quickly as possible so that we can focus on the delivery of care going forwards. It sets out the latest position in terms of right-sizing the Integrated Care Board as an organisation. So colleagues will be well aware of the change and reduction to the running cost allowance that's nationally mandated in terms of that reduction, and so the programme to deliver that is now well underway. The intention at the January board will be to bring a more detailed paper around the operating model and what that will look like before we then enter into a formal management of change period with the staff employed in the Integrated Care Board. We've touched on heavily the Armed Forces Covenant, but obviously fantastic to sign that with Colonel Dutton and colleagues previously, and I think from the ICB perspective, there's some feedback. Thank you. That wasn't linked to the ICB perspective. Then I think looking to both of our local authorities and to our NHS organisations, provider organisations who are already well down this road, I think we recognise our role in terms of that facilitation, but there's bits that we can learn from the areas that have already got gold standard and silver awards in that space. So fully commit to working in that area. Given my background, then we reference the work that took place on the National Allied Health Professions Day. We update on the activity across the NHS in terms of the Black History Month. I think one of the bits to flag, I guess, there is there's a lot that's gone on. I sometimes think, could we be better at how we really coordinate and maximise these events as a system, because there's a lot that happens, but it's in bits, and that's really important that those bits happen. But actually, what would the focus and attention be if we did that in a more coordinated and more joined up way, and what's the potential? I don't just limit that then to Black History Month. I think about some of the wider campaigns and some of the wider approaches. So I'm going to ask colleagues to really think about how we might still want to do that within our own organisations, but what would an overall approach look like that would really get some momentum and some focus and profile around this. I update on some national guidance that's been released, which is probably not got the sexiest of titles in terms of the provider selection regime, and everybody thinks, what does that actually mean? But actually is a really important piece of national documentation. The reason for that is it moves NHS providers and commissioners away from significant competition in terms of procuring and tendering. And moves us much more into a collaboration and integration space. So you'll recognise that some of the national policy framework is playing catch-up to how we've been trying to work for a period of time, and these are some of those national building blocks that we need to be put in place to enable us then to really think about how do we avoid going down a procurement and tender route, but still have a focus on driving for high-quality outcomes for the residents that we've got responsibility for. Recognise that our comms and engagement team recently won a national award in public sector value for money for the Think Which Service campaign, and were highly commended for the in-house public sector team of the year award, so recognise that. And then I touch on, and a lot of people have been interviewed and had conversations about the governance review that's been taking place, led by the Good Governance Institute. Not intending, Chair, to go into detail around this here, but to flag the work that's taking place. Had a very brief initial conversation at Chief Exec's this morning, and the December meeting is going to focus much more on this and on the place agenda, with the intention that we bring back a more formal response to it and output from it into the January board. And I'll pause at that point, but happy to take any questions or comments.
Thanks, Simon. There's a lot of material there. Let me ask you if you have any questions. Can I, whilst people are thinking, can I just ask about the review, the governance review? Harry,
I was going to ask a question about it as well.
No, right, well, you go first.
Well, it's probably not for answering here, Simon, but clearly the governance review was commissioned some months ago now, and several things have moved on since. So will the review take into account where we are today rather than we were 3-4 months ago?
To be fair, Harry, that's exactly why there's been some bit of a delay on this, because it became really clear that developing something that was drafted for what would have been fit for purpose for 3-4 months ago isn't fit for purpose now. So actually what it's likely to indicate is a position that we should move to almost immediately, but it will also indicate a direction of travel as to what the future might look like 6, 12, 18 months down the line. If we think about where place development might get to, we think about where provider collaboration might get to, the intention is to signal a direction of travel around that.
Yeah, thank you.
My question was sort of related to that, Harry, because this is such a moving landscape. Can we be assured that before it comes to the board meeting in January, that committee chairs have had the opportunity to be consulted about the kind of contents and the recommendations that might affect their committees? What I don't want is for people around this table to see the thing for the first time when it's published with the agenda towards the end of towards the end of January. Harry, did you want to?
Yeah, just to add to that, I think it'd be worthwhile as well letting our individual governance leads engage with it, so that the trust governance and the system governance are synchronised.
So I think those really important points. So if we can pick up 2 actions from there. So I think really sensible for me to sit with chairs of our subcommittees and go through the governance review in the same way as the chief execs will be having that conversation. And Alison, with you, I wonder if we can pick up the governance lead conversation, because I think that's really sensible as well.
Excellent. Meredith.
Thank you. I was tempted to ask if my red light was on, so I knew if I had a question or not. You didn't say, Simon, but can I just check the GGI report will inform, go into the kind of the thinking around the operating model? I'm sure it will. You almost don't need to answer that. But more substantively, you're mentioning Black History Month reminded me that I don't think we ever had a board discussion around the very difficult reading of the rural racism report. If we did, then I missed it, and I apologise for that, but I did think there was some important really important information and evidence in that report that we needed to pick up. I just wanted to get your reflections on that.
So I think so 2 points. Let me pick up the first one first. Then in terms of the governance review, the whole intention is that it picks up that operating model as well, and it thinks about what's the management side of the organisation versus what's the formal governance and assurance side of the organisation, and how do we make that clearer actually and better understood. So yes to that piece. And I don't think we've had, I think you're right, Meredith, I don't think it's come to the board in terms of the rural racism. I know that we've picked that up both through exec team and senior leadership team, and then with the events that we've had in the system where it's been talked about and presented, but I don't think we've had a formal board conversation about it. So we'll put that on the forward plan, Chair, and bring that back. Given the time from when it was written, I would suggest that what it comes back with is both the action plan, sorry, the plan that talks about what have we done as a result of, as well as what we intend to do going forwards, rather than just bring the report to discussion.
Thank you.
I just want to build on that because it strikes me that as a board we've not turned our attention in any detail, apart from important prompts from our directors of public health, to the issues of rurality, access, inequalities, health in general. And we've not turned our attention to any issues, arguments about funding for us as an ICS in terms of the resource allocation formula and rurality. So I wonder whether this is a topic that we should have, for which we should have a board development session in the round. And I don't know how you feel, Meredith, we might pick up the rural racism issues as part of that discussion rather than it being seen to be sort of standalone. Now, that might mean a little while longer before you get the kind of response that you've asked for this afternoon, but what do you think?
I think there's a risk of it being diluted if
Okay.
we throw our net too wide.
Sorry, Chair. So I think there's something about the rural racism report, the board seeing that and it coming formally through the process. I think the points that raises and talks about in terms of the impact on staff and workforce, I would want to make sure that our people committee have been looking at that as well and working through that. So I think there's alignment of our governance in that space. I think the second point, Chair, which you raise around the issue of rurality, the challenges of delivering services across a rural footprint and where we're trying to get to with the place development piece and what that looks like, I think that's absolutely the space for a board development session, and we should be bringing in the funding conversation into that space as well. And I'd like to do that with both DPHs if that's okay. Yep. Everybody happy with that? Julian? And then Roger?
Question about another part of the report, if that's all right.
Oh, well, did you want to make a point about...
Not on this one, no.
Not on this one. So I think we're agreed on two specific actions there, which we'll follow up. Julian, I think you were just next, and then Roger.
So mine's just about the shaping the SWICB programme section of your report, Simon. And just three quick things that you may not be able to answer now, but I suppose the first one is about Clarity Consulting Associates coming in to help develop a new mission and values document, and will the how will that be done, and will the ICB board be involved in that setting the mission and values, or is it going to be built up from the staff upwards? I suppose the other one is about the impact around the reduction in running costs and on the actual operating model on our workforce, and is there an impact on our workforce, and if so, what are we doing to support our workforce? And the third bit was just more about clarifying about the reviewing our agile working policy. Is that to get more people back into the office, to get more efficiency, or is it to keep more people out of the office to allow more efficiency? I'm just not sure which one it is.
So I'll deal with the last one first, if that's okay, Julian. So the Agile Working Policy has completed its process of consultation with the staff. It talks about an expectation of pro rata 40% of your time being back into the office. So the intention is that for a full-time member of staff, 2 to 3 days will be back in the office. That aligns with us also moving offices and moving to a council, a Telford and Wrekin owned building in Wellington. So I was also keen to make sure, and with the help and support of David and colleagues, that we end up paying our rent into the public sector rather than to a private sector landlord. So we were committing to that piece, as well as David wanting to make sure that that's as cost effective as possible for public sector colleagues and partners. So that fits with that piece. In terms of the support offer, that's for staff in the ICB, that's being developed and worked through now because there will be an impact on people. There's a clear timeline that I presented to staff both at the huddle a couple of weeks ago and at the development day last week. The important bit there, though, is we're not starting from a position of structures. We're starting from a position of the operating model, what are our functions, how do we work, and then we'll develop the functions that then play through in terms of that. So it will impact on people and colleagues in a different way, and we're really cognizant of that impact. The timeline means we will be launching the operating model pre-Christmas. But we will not be starting the management of change until the first quarter four in 23-24, so later in this financial year rather than calendar year. So working through that. And then your first question, which was around values, principles, it's going to be both. So there's going to be the bottom-up piece, so staff have been inputting into that and we've been doing some work in that space already anyway, and then coming back round then to do the socialisation of it and the sharing of it and saying what does that mean and what does that look like and how does that resonate, and we've got to then join that in the middle in the right way. So the intention is to do that from both directions.
Thank you. Roger.
Yeah, my question is about the provider selection regime.
Yeah.
I just wondered what your view was around the impact of that going forward, both on ourselves, local authorities and providers within the ICS.
I mean, I think the impact aligns with the approach that we've been wanting to adopt and take anyway. So the intent that we've set out towards integration is that we want provider-led integration, and I use provider in its broadest sense, not just limited to NHS, but this is an NHS provider selection regime, and for integration to be, so improving outcomes for the population through the delivery of integrated care to be the key driver in all of this, and then our framework and policies sit alongside that. What we had previously would be a situation where that might be our intent and where we'd want to go as we develop new services, but we would need to put those out to tender or go to procurement, and we risk further fragmentation rather than driving integration. So the experience across the country has been, if you end up in that space, there's a risk that by going through tender and procurement, you increase fragmentation when your intent is to drive integration. So what this enables you to do is be more pragmatic in that space. I think the risk in that, the other side, is how do you make sure then that you're getting the outcomes and the standards and the improvement that you want if you can't use tender as a lever to drive that. But my personal experience would be it can be a very blunt tool and not always give you the outcome that you want, but the board will need to be cognizant of making sure that what we do from an integration point, and certainly when we get into the provider collaboration conversation, how the board gets assurance of the improving outcomes for the population will be fundamental to supporting the ongoing development of that way of working.
And in terms of local authorities, are you signed up to this process, Andy and David?
I don't think they have a choice.
So this is from the Department of Health and Social Care, so anything that impacts from a social...
Local authorities as well are involved.
From anything from a social care provision point of view will have to go through the same framework of the provider selection regime.
Okay, there's a question that I want to come to in just a moment. I suppose, Roger, your question has just prompted a thought in my mind. Is this, Simon, do you think, a national policy that we should make sure we comply with as and when the need arises? Or is this a national policy that we can use to create new opportunities to improve the services that we currently offer?
I think this is national policy catching up with a Health and Social Care Act that drives integration, and the policy framework wasn't aligned to that.
So that doesn't answer my question.
No, I know, Chair.
So what's your view?
I think this is policy catching up with legislation. This is alignment of policy to statute. And we'd got a mismatch previously. So it supports the drive towards integration by removing elements of competition, but it doesn't remove it entirely. It remains an option. So as a commissioner, you still have that option, but the preferred route is to work with current providers to drive integration.
So let me try again. If we take this new policy, and I think we'd all understand the philosophy that underpins it, could you, for a future meeting and the executive, give us advice about where you think we might apply it?
We can, Chair.
Thank you very much indeed.
It's for all healthcare contracts.
Sorry?
The policy itself applies to all healthcare contracts. So at the moment, once it becomes law, our goods and services contracts will still be under the existing goods and services arrangements, but all of our healthcare contracts will have those new rules applied. Tender is always an option in any of the kind of gateways we go through in terms of assessing how we do our procurement, but it does give us additional flexibility through law that we didn't have before.
Yeah, I always think that this kind of policy should be viewed through the lens of, does it give us opportunities that we've not had in the past? And I can't work out whether it does or not, hence my question, really.
Yeah, we could do a few for examples in each of the kind of gateways that you pass through in the thinking.
That would be useful.
Yeah.
Julian, did you want to comment on this? Because I'm conscious of a...
Just there's a very important bit within the PSR for primary care that might be helpful, in terms of that the PSR allows from the 1st of January practices to convert their contracts to limited liability partnerships as opposed to being unlimited liability partnerships, which previously was quite difficult to do because the practice had to give back its contract and there was a risk that it would have to be, there was a legal process to go through about whether it should be retendered, whereas that removes that. So practices will have the ability to consider whether in fact their structure is better served through limited liability partnerships. And that I think is a very positive thing, because one of the things that discourages young GPs for taking on partnerships is the unlimited liability that the older generation of GPs, just around this table, face. So I think that's a very positive part of the PSR that's hidden. Having read the policy, I'm not sure it does make things much more easy. I think it's going to be a lot of potential for challenge around have you interpreted the 3 different scenarios correctly. So I think it's out of the frying pan into the fire.
We'll bring something back.
Let's have another look at it in terms of potential opportunities. But clearly, this is not straightforward. But let's see. Another question.
Yes, going back to the rural...
I can't hear, I'm sorry.
The rural deprivation question, it was just a request that if you're going to do that at a board development session, can the VCSA be involved in kind of the development of that? I think we've got a lot to bring around access to services and EDI, community transport schemes, etc. So it'd be great if we could be involved in that.
Really good point. We have an awful lot to learn from VCSE about these things, and we'll make sure you're fully involved. Thank you. Any other questions for Simon before we move on? Because the next item is, excuse me, the really important issue of the hospital transformation programme, for which we've got Matthew, Neil, and is it Ed? Hello, Ed. Ed Rysdale. Now, it's kind of standing room only, so I hope you've got a couple of seats. That's great. We're keen, gentlemen, and as you know, these gentlemen are well known to this board, presented previously. We're keen to just get an update from you, and from Claire of Louise, I'm not sure to whom I'm turning, some advice about the process that this board needs to undertake, because presumably we have to submit a letter of support for the full business case. And I'm not quite sure about the timelines and how we're going to organise that, but I'm sure greater minds than mine have given some thought to this, and I want to pick that up as well. But, Matthew?
Louise, to start.
Oh, sorry, Louise, you're kicking. I do apologise.
No, that's fine. Yes, as you've identified, this is a key programme for us to improve the healthcare and outcomes of the population we serve. I was going to hand over actually to my team, Matt, who's the director of the Hospital Transformation Programme, and Ed Rysdale, who's one of our emergency medicine consultants, who's also leading on this with Matt and the broader team. And they can take us through that, Chair. Thank you.
Thank you, Louise. Over to you, guys.
Okay. Can you hear me, everyone? Thank you. Yeah, thank you, Louise. So this is just to take everybody through where we are.
You might want to pull the microphone closer to you.
Sorry. Is that better, everyone? Brilliant. Thank you. Thank you, Simon. So just to take everyone through the Hospitals Transformation Programme, give a bit of an update, and then answer your question, Chair, as we walk through the presentation. So what I wanted to go through today was where we are in the process, latest developments, and the next steps, which picks up on the full business case process, and then answer any questions that colleagues around the table might have. Where we are in the process, this is a slide that we've shown at previous events, but also at some of our public engagement events and our focus groups that we've been holding fairly recently in terms of the outline business case and the strategic outline case, and where we are in that process. This winter, we're hoping to complete the full business case and submit that through the approval journey. That's the final hurdle in the approvals process, and then hopefully we are then into the process of implementation. Most of you will have hopefully seen and noticed that there was an announcement in Parliament recently around our funding for full business case plus the enabling works. So we've been proceeding on the basis of the enabling works, and we've done a lot of work around that, and there are plans to start that work as well this winter in relation to the enabling works to our emergency department, which hopefully you are all kind of aware of what's happening with the refurbishment there. The next slide is just to give you a bit of an update again around the clinically led changes and the model, which has stayed the same throughout the process of the DMBC, but also the outline, strategic outline case and the outline business case. I'm going to hand over to my colleague, Dr. Ed Rysdale, who'll just give you a bit of an update on that slide as well.
The further away we are from the screen, the less chance we have of being able to read the detail, which for some of us doesn't matter so much because we know it pretty well. But Ed, if you could just help us with some of those headlines.
Yeah, so I think a lot of you may well have seen this slide before, but this just explains where the services are going on both sites. So both sites will have some combined functions. So there'll be urgent care centres at both sites. The one at PRH will be an enhanced urgent care centre using the A&E local model, which means that anybody who walks in can be seen and sorted and discharged on the same day. We'll be doing that, and that's been enhanced over the period of time with the addition of the same-day emergency care service alongside it, a 12-hour SDEC. So the acute physicians are going to be based alongside the front door in Princess Royal. So if they need a bit longer than you'd normally have in the urgent care centre or an emergency department, as it is at the moment, but will change, they can then be seen, kept in Telford and discharged on the same day. There'll be diagnostics, so CTs and ultrasounds and pathology at both sites, diagnostic endoscopy at both sites, planned outpatients for adults and children for both sites, and there'll be day case cancer services at both sites. And then Princess Royal is specialising in planned care, so all of the non-complex planned care will be happening or the vast majority of non-complex planned care will be happening at the PRH site. And what we mean by non-complex is surgery that is unlikely to or won't require critical care, because the critical care unit is being amalgamated onto the emergency care site alongside all the acute specialties. The women and children's moves across to the emergency site because of the clinical adjacencies aligned to that. So gynecology aligned to surgery, the maternity with the intensive care unit, the paediatric unit alongside surgery and the emergency department. So all of the clinical linkages come together, and that's at the specialist site. And that means that the inpatient children's unit is at Shrewsbury, and therefore the children's surgery will be happening at Shrewsbury as well because of the nursing requirement, paediatric nursing requirements for it, and that's always been the case from the get-go. There's been some questions about that, so just to make it clear that children's surgery will be at the Royal Shrewsbury site, and as has been said, but there will be planned children's care at Telford in terms of outpatients, and also children will be able to go through the urgent care A&E local model. But all the specialties at Princess Royal, so general surgery, urology, gynecology, orthopaedics, bariatrics, so the weight loss surgery, will all be happening, and breast surgery will all be happening at the Princess Royal site. And then head and neck services will come across, as I say, alongside the children's unit and the intensive care unit into Shrewsbury as well. So that's just an overview of the clinical model. Nothing's really changed from it, but just making clear, because there have been some questions over the last few weeks as to what's going where and why, and that's a brief overview. So PRH will become the specialist site in planned care. And that's already started with the planned care hub. That anyone who's been to PRH recently will have seen the new front door, and that's part of the planning. It looks very good, but it's actually moved the offices to the front so that we've got space to do the theatres at the back. So the 4 new theatres will be opening shortly for day case, and that ring fences our day case services, so we can actually continue operating throughout the year. If anyone has been aware of the pressures, you probably all are, the day case unit at PRH at the moment is often used by emergency and urgent care patients who we need space to get them in. So this will ring fence and protect the planned care pathway. And the majority of our operations that are done at the Trust are done through a day case service, so this will add into that. So that's progressing well and will be online later this financial year. I think it is this year, but that will be confirmed. And this ties into it. So it's not part of the HTP programme in terms of the financing, but it's absolutely a key part of the whole programme. So that's the ongoing discussion around the planned care hub along with HTP. So RSH becomes the site specialising in the emergency care site. That's an artist's impression of what the architect says it's going to look like at the front of the site as you come in off the Copthorne Road. Emergency department alongside theatres, radiology and the acute floor. So it'll be an emergency floor and an acute floor on the ground floor. Urgent treatment centre alongside the emergency department. A new 32-bedded critical care unit in the new build on the top floor. Consultant-led maternity care and midwife-led maternity care. And there'll be midwife-led units at both sites, both Princess Royal and Shrewsbury. Emergency and trauma surgery at this site. Talked about the children's unit coming across, and alongside the paediatrics will be the consultant neonatal service on the same site on the same floor as delivery, and the head and neck services coming across as well. So that's what will be at the RSH site. So back to Matt for the update.
Okay. Thank you, Ed. So in terms of where we are in the process, we are continuing to work with our clinicians around the detail of the design and designing the flow of the clinical services. So working very closely with the divisions at the hospital. We continue with our colleagues at Shropshire Council to seek planning permission, which is underway and has been for some time. We're working through that with colleagues in Shropshire Council. We are making preparations now to implement the building works and the enabling works that are happening on the site as part of the refurbishment of the emergency department. And we are undertaking, and hopefully most of you will have seen, a number of focus groups, engagement events with the public around the model. And we continue to encourage a membership of a number of focus groups to help inform the plans that we're pulling together. And that won't just happen over the next few weeks or months. That will continue on for the next number of years as we implement the new clinical model and as this programme develops. So to pick up on your point, Chair, in terms of the main areas of focus and next steps over the next few months, hopefully securing planning approval. We're finalising the design, so we're now down to a very advanced level of detail in respect of the design of the actual the new emergency department. So significant work there around floor planning, even down to where desks will be located and plug sockets and that side of things. So a lot of advanced work done in respect of that. Engagement around some of our travel and transport plans, and a travel and transport focus group has been set up specifically. One of the big themes that's come out of both the planning engagement events, but also our engagement events and focus groups with our communities, our patients, our staff, are also helping to inform the plans, and that will continue on. Continuing to work with yourselves and across the system around the local care plans. We continue to work around that as part of the programme board that we've set up across the system. Planning, as I say, for the implementation, including sort of logistics and transition. For those of you that know the Royal Shrewsbury Hospital site very well, for example, it's a very constrained and confined site, so there's quite a significant amount of logistics and phasing and transition that will need to happen to enable the work to go ahead with and to operate, so it doesn't impact on the hospital. And our plans are absolutely to ensure that the hospital functions throughout the development, and there's been a lot of thought and work that has gone into that. We'll be continuing our public engagement, as I said earlier, and that will just ramp up over the next few months and years in respect of talking through the proposals, and also answering any questions and responding to any requests for information that colleagues and the public have. As I say, we'll be looking at commencing the enabling works, which is within the existing emergency department. And as you've rightly pointed out, developing the full business case, and also seeking a letter of support from this committee, which will probably, from the board, which will be in the next few months, Chair. So that's our current timeline. So happy to answer any questions, colleagues.
Thanks very much indeed, Ed and Matthew. Let me hand over for any comments, questions. Nick?
Yep, thanks. Really enjoyed the presentation. Bit of a challenging question, but with regards to the design of the estate, are you building a hospital which is just going to be okay for 2024? Or are you just being really ambitious and building a hospital which will be exceptional in 2028?
Definitely the latter, but I'd like to think it's exceptional beyond 20... Did you say 2028, Nick?
Yeah, okay, 2038 if you like then.
2038, 24... So we are building it with flexibility absolutely at the heart of it, Nick. So the idea being obviously that healthcare will change during that period, and making sure that the building can adapt to those changes going forward, but still be able to deliver what we need to deliver now. So that's built in and inherent in the plans.
Thank you, Nick. Any other questions? Julian and then Roger.
I've just got a couple of questions really. I mean, and they're both related to sort of transport really. One is about planning for the increased numbers of patient transfers between sites, because obviously there'll be a lot larger number of patients being moved from one site to the other, and I think it's what works ongoing both with the ambulance service and with patient transport around that, and also around staff movement between the site. The other one is something that I think both Princess Royal and Royal Shrewsbury have in common at the moment, is the going through the gateway is like entering the Wild West in terms of parking. If you don't arrive there by 9:30, you have to have a four-wheel drive and park on the middle of the verges in Princess Royal, and in Shrewsbury it seems to be the double yellow lines of where the overflow car park is. So I suppose what are the, with the building works that will be happening, what are the plans now for improving parking and transport plans? What are the plans for during the building works? Presumably most building sites will encroach upon the current ground, so I assume we're going to lose parking. And what are the plans moving forward? Because there will be a lot more cross-site transfer of patients, and a lot of those will be using their own transport. A lot of them will be using public transport, so there's a question around the travel plan for that. But it's really about, have we really looked at that in depth, and what are the plans for that at the moment? And what are the plans now for parking? Because if I hear anything from my patients, it is this: if you arrive after 9:30, you are in trouble in terms of parking.
Matthew, did you want to deal with those questions?
Yes, thank you, Chair. I will call on Ed to help with some of it. You're absolutely right. Parking has come up as one of the biggest issues in relation to the focus groups that we've had but also as it's come out in the planning engagements events that we've had in respect of the Shrewsbury Hospital. In terms of Shrewsbury Hospital, we've had a significant bit of engagement with the highways, but also with our communities. And there is a quite a detailed travel plan that's been submitted that kind of details the different ways that we will deal with the site throughout the construction process. You will, you're right, things, but that's something we'll be addressing throughout the construction. We really need to do something now. Some of the things we've put in place in relation to Shrewsbury are, for example, working with colleagues at the local authority around some of the park and ride that is again at Shrewsbury. So that's some of the things we're doing at the moment in relation to parking. At Telford, again, you're correct around obviously the parking there as well. At Princess Royal Hospital, again, there are some spaces that have been freed up now due to the contractors being able to bring back hoarding from the reception piece of work, but that is still something we're looking at ongoing, and we mentioned that at the travel and transport focus group that we had with the public a couple of weeks ago, because it is a big issue. We've also been going through with our communities at Shrewsbury and as well at Telford, what are the alternatives to car travel, and what are some of the big issues that affect our patients in terms of accessing the sites, and some of the things that have been raised are around, for example, the rurality of some of our patients and communities. So how do we get over some of that stuff? So and there's quite a detailed action plan that's come out of that, which we're working with our colleagues, we're working with local authorities, we're working with community transport providers as well as the transport providers themselves to help with some of that work. But again, it's ongoing. It's not going to happen overnight, and we recognise that. So we're working. So we have a detailed plan that we're going to work to. In terms of the transfers between sites, Ed has alluded to the enhanced urgent care services that will be provided at the site. We've been consistent in saying that we believe over 2/3 of our patients that currently use the A&E, for example, at PRH, will continue to do that under the plans. And there were some very detailed plans around ambulance transfers, detailed as part of the DMBC, the Future Fit proposals. So we're working with our colleagues at West Midlands Ambulance Service. I was on a phone call to one of their senior directors this morning, just talking about some of this and how we take things forward. And obviously I've been working very closely with Simon and colleagues at the ICB around what we do around commissioning the ambulance services as when the model comes in a few years' time. So all of those things are being put in place and are being thought about and form part of the programme, just to give some comfort around that.
Thank you very much indeed. Ed, did you want to add anything?
Yeah, just an important point about the patient transfer in between sites. As you alluded to, there will probably be more increased planned transfers from the Royal Shrewsbury to the plan care site as part of the clinical model. But on the flip side of that, at the moment we have quite a few unplanned emergency transfers between sites for patients going to the wrong site. So surgical patients being in Telford and children's and women's services arriving in the emergency department at Telford. And that takes up quite a lot of time and resources in terms of emergency transfers. It's much easier to organise and safer to organise planned transfers across sites. So we'll have a marked reduction in the unplanned emergency transfers that we have because of our split site services at the moment. So that plays into the discussions as well. But we have to open these discussions with YMAS and with the urgent and emergency care part of the ICB to looking at how we commission these out going into the next couple of years, because it's an absolutely vital part of the programme.
Thanks very much indeed, Ed. Roger.
Yeah, a couple of questions. First of all, I'd like to know more about the flow issues you mentioned in terms of involvement of the consultant body and how that's going and any challenges emerging there. And the second one is around the communication to the people of Telford and Wrekin around where do they go. So if they have crushing chest pains, do they go to the PRH or do they go straight to RSH? And how is that going to be handled in the future? Thank you.
So in terms of flow issues and patients going through, obviously, being an emergency medicine consultant, it's very close to my heart that we need to get flow right to get patients through my department into the hospital and actually, more importantly, out of the hospital in a timely manner, because actually we don't want patients residing in the emergency department or actually outside the emergency department. So flow is absolutely key. And we're working very closely with the ICS and the Local Care Transformation Programme to make sure that we have the right numbers of patients in the right place. We want to have as many patients at home as we possibly can do, so the things like the virtual ward. In terms of speaking to my consultant colleagues, there's been, I can honestly say, no pushbacks in this is the wrong thing to do, because actually we can't continue as we're doing at the moment. When we split services 10 years ago, there was a lot of discussion about, are we doing the right thing in splitting services? I've been a clinical lead now with this programme for just over a year. It was November last year, and I have had one anaesthetist who was new to the trust who asked why we're doing this rather than are we doing the wrong thing, because they were concerned about having no intensive care at the PRH site. But when we explained the rationales and behind it, they understood it. So that's the only one who's a new starter in our new thing. So there's been no pushback from the consultant body to me, and as far as I know, to the rest of the team, which to me is quite phenomenal, because consultants aren't shy at voicing their opinion when we think we're doing something wrong.
That's very true, Doctor. Matthew, the important point about communications with residents, about where to go, really.
Thank you, Chair. So again, we've been undertaking a significant amount of communications over the past few years, but has significantly ramped up, as I say, over the last few months. We've been talking to the public through our focus groups, through our About Health events, advertising the new clinical model, talking through the slides that you've seen today. And we are going to be doing more in terms of publicity over the coming months and years. We've also been welcomed clearly and throughout the process by our local authority partners. We've met, for example, with Shropshire Council councillors to run through this and explain the model in detail, and we're also due to meet with colleagues from councillors from Telford and Wrekin Council to run through the model as well in the next week. So there's lots of work that we're doing from a publicity perspective, and we will be doing more and advertising more around each of the services, not just the enhanced urgent care services, but we're doing a lot more in respect of some of the other services as well. And we've got specific groups that are now set up for each of the specialisms to go through what's being planned and what the model will look like in the future.
Okay, Ian?
Can I just add to that slightly, and just that there are part of the engagement as well is going to get the public, or try and encourage the public to dial 999 in emergency, for example, with a crushing central chest pain. But if they're not sure, dial 111, and then they'll be directed to the most appropriate place as well. But if somebody does turn up to Princess Royal, the team there, they're open 24 hours a day. If the example you gave of somebody with crushing central chest pain, they would have an ECG, and if it was showing they were having a heart attack, as of now, they would be transferred over to the appropriate place over in Stoke at the moment. So if someone did turn up at PRH, they would still be seen, assessed, and then directed to the correct place, wherever that may be it Stoke, Shrewsbury, or if they can be treated, seen, sorted and discharged on the same day, they will stay in Telford. But we will encourage people to use 111, and they'll hopefully be directed to the right place in the right time. So that'll be part of the communications over the next couple of years. But we'd encourage people to use 111 now as well, because they're very good at directing to the correct place.
Okay. We'll get plenty of other opportunities to talk about this, but let's take the last question from Ian, or points.
Yes, thank you, Chair. I attended the EUTC and A&E local model planning workshop earlier this month. I can see this work starting to take place, specifically around Telford. I think what will be useful is those detailed pathways specific to Telford. I think at some point the board should have a visibility of that, because there's going to be quite a bit of difference between the pathways in PRH and RSH.
Agreed?
Agreed, yeah.
I gather that I've missed Meredith, and I think David Sidaway wanted to come in as well.
Thank you very much, Neil. Very quickly, so I'm going to give credit to Nigel Lee for this contribution. I think it would be a very good idea, before it comes formally back to the board, just to go to our Equality and Involvement Committee, just so that we can hear the evidence base for all the work that you've been doing, and we can assure the board that we're very comfortable with what's been done, or indeed there might be something not quite done that we can suggest. One big issue for me is I would want to be sure that all the engagement activity hasn't been about telling the public what's going to happen, rather than this is what we plan to happen, can we have your comments please? So it's as much engagement as communication. That would be one of the tests I'd be interested in. But anyway, just to say it might be helpful to the board if we can do that assurance around equality and involvement before it comes back.
That seems very reasonable. Thank you very much indeed, Meredith. And before I just hand over to David, I don't want to steal David Sidaway's thunder, but I did want to make the point at the end of this discussion. We should bear in mind that the Secretary of State has asked the independent reconfiguration panel to review the planning assumptions, for want of a better term, that were made at the point at which HTP, what was it called? The pre-consultation business case was approved by the CCG, and that process is underway at the moment. We don't know what the outcome will be. It'll be a report for the Secretary of State. But meanwhile, we've not been discouraged at all. In fact, to the contrary, we've been asked to continue with the work that is in train, and that's exactly what you've been hearing about today. Now, David, I didn't know whether you were going to comment on IOP or not, but I wanted to make that point, but over to you.
Just really quickly, David, apologies. Because we're in a public meeting, Chair, and for accuracy in terms of the minutes, the Secretary of State's asked for advice from the IRP, not asked for a reopening of the case or the decision. So it's a subtle nuance, but it's a really important nuance in terms of a public meeting, in terms of the board.
Thank you. David.
Thank you, Chair. I wasn't going to mention the IRP, but as you mentioned it, it's interesting that we referred this in March of this year, and we only received a response 6 weeks ago. So I guess that's given us a bit of an indication. I would just like to say thank you to colleagues, because they have offered and delivered updates to the leader and myself in recent times, and thank you for offering to meet with all elected members at Telford and Wrekin. I think it's next Thursday from memory, so that's really very much appreciated. But you won't be surprised for me to say, on behalf of Telford and Wrekin, we oppose these plans and we'll continue to oppose them. So sorry if that sounds like a stuck record, but it's important that I make that point every time this comes forward, and clearly when the final business case comes forward in the next couple of months, I'll be doing the same as a member of the ICB. The one thing I'd like to add in the last three comments I just heard from colleagues is around the pathway, around the equality, and other comments is explaining to the residents of Telford and Wrekin what an A&E local is and isn't, which is in line with the comments from the last three contributions to this board. It's really important. There is a risk associated with it, and it does cause us much concern. Thank you.
Thank you very much indeed, David. There's nothing you've said that I guess would surprise us. We understand why you're making the points you've just made. We continue to work with you in the hope to perhaps provide some Damascene moments for you and your colleagues. That's probably more in hope than expectation. We understand your views are very, 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 very strongly felt. The views of your council, of course. I'm going to move us on, Louise, and just ask you, was there anything in summary that you wanted to say at this point?
No, I think that's covered it. I would just like to thank everyone for their engagement and involvement in this key programme. We welcome the feedback and we'll continue to build on that as we go through the next steps. Thank you.
Thank you. Matthew, Ed, thank you once again for coming here. We'll see you again soon, I have absolutely no doubt. Very grateful to you for all of the work that you and your teams are putting into this. We'll come to the local care programme and update shortly, but meanwhile we want to turn our mind to winter planning, and we're running a bit behind schedule, but this is important. This is a topic which deserves some fairly comprehensive consideration and updates. I suspect that we won't be hearing today that we have a signed and sealed comprehensive integrated winter plan, although if we do, that would be wonderful. I know there's a huge amount of work going into this as we speak, and I guess, Gareth, I'm turning to you just to open up the discussion. Tell us what we've been doing since the last time we discussed this, which was at the board development session from memory, where we talked about capacity gaps and responses to that. And tell us what you need us to do.
Okay, thank you, Chair. So given importance, I won't take the paper as read fully. I will just walk through some of the key aspects of it. The winter plan document, the full document included within the paper deck, sets out the consolidated approach to delivering care across system partners, as Neil described at the introduction, to safely navigate the challenges that the system faces for our patients. It's been worked up and developed in conjunction with all system partners and sets out all aspects of our operational plan, the winter subcomponent of that, if you will, because this year more than most, the actions that we're taking to work us through winter have been taken predominantly all the way through the year. The covering paper, although the detailed document takes through all of the aspects of contribution from all system partners, and there are many parts to it that are worth review, the covering paper highlights the particular area of focus that I'd like to bring the board's attention to around the proposed bed deficit position. At the start of the year, we proposed a system operational plan that had a bed surplus going through the winter months off the back of a number of planning assumptions and operational changes that were going to be made through the year, particularly around the use of the virtual ward and subacute wards. However, there have been a series of changes that have impacted on that bed model, which now leave us in a position of having a significant bed deficit as we approach November and going into December through to March. Those key changes are an increase in demand, which is requiring a high number of actual beds within the acute setting, the virtual ward delivering a lower impact on acute beds than anticipated, partially due to some modelling assumptions which are erroneous, and partially due to the way that the challenges that the virtual ward has faced on implementation. There's been a slight delay to the implementation of the subacute beds coming on stream in January rather than December, and there's been an in-year deterioration against plan of the no criteria to reside and ready to go patient position. What this means is, and although there were a couple of minor discrepancies between the covering paper and the detailed document itself, the detailed document sets out the current position of a shortfall of 91 beds in November, reducing to a shortfall of 30 beds in March. The paper then sets out a series of interventions that are planned by system partners, which are covered in the document in detail, which I won't go into now. But those interventions, if delivered, can improve the bed position by 110 beds, resulting in a broadly balanced position. However, those interventions are interventions we've been working on throughout the year with mixed success. And therefore, it's important for me to highlight the fact that the result of only a partial delivery of those interventions will put us in a position where we have to make some difficult choices around how we care for patients. Just bear with me 1 second while I bring up the specific notes that I want to refer to. Section 4.4 of the document sets out the implications of these interventions in terms of caring for patients in unconventional care areas, for example, fit-to-sit areas or the respiratory investigation unit, where the evidence is clear that clinical risk increases with the length of time patients remain in these settings. By accepting the use of this space, NHS STW is required to accept that impact on our patients. We need to be really clear that although there is a bed deficit position of 110 beds within the model, 91 beds within the model, the use of these unconventional care areas does not represent a place that we would wish to care for our patients, and these are the spaces that we would use in extremis. The only additional option that we have on top of the use of those spaces is to deploy the full hospital protocol, which then results in the cessation of certain elective activity, which would be as difficult a decision for the hospital and the system to take. I'll pause for breath there, Chair, before I go on to the specific ask of the board, because there's an awful lot within that paper that may be worth discussion, and then perhaps I can make the asks of the board at the end of the discussion.
Okay, I'm going to turn to Simon, because I know this was a subject of a discussion at the Chief Executive's meeting this morning. Do you want to add to that which Gareth has briefed us about?
I think Gareth has covered the main points. I guess the important bit is we are already in a situation where some of that unconventional care spaces is in use and being utilised. So equally, I wouldn't want us to sit here and say we're in a comfortable position now as we head into December. The system has been under pressure all year. It continues to be under pressure. Partners are working relentlessly to improve in the areas that have been highlighted and talked about. There was a lengthy chief exec conversation today with a number of actions that come out of that for all partners to go back round the loop on a number of the areas, both in terms of no criteria to reside, the ready to go, the actions within a hospital, within the hospital, within SAT's responsibility, the ask of our community provider and mental health provider in that space to look to further provide assurance around the delivery of the mitigating actions, but also to really make sure that we have considered every opportunity, because as we sit here now, we recognise the challenge that this places in terms of how we navigate the winter period and the ask we're making of both staff and the impact potentially we're having on patient care in that space, Chair. So I think Gareth will probably want to take us through the recommendations in a clear way, but I think there's an important piece here where whilst we might be noting and recognising the improvement of the position as set out in the plan, it's an ongoing piece of work with colleagues continuing to work on this. Even as we speak now, actually, people are undertaking bits of work to continue to develop the response, and we're doing that at pace, given the challenges that have been set out.
Thank you. Does anybody else want to comment at this point? I mean, clearly, we've had disappointments in terms of the availability of capacity that we'd hope would come online very soon now. Clearly, we have continued to strive hard to make greater use of the virtual ward, and there's some signs of improvement there, but there's still capacity there, and it's not just a question of easily moving patients from hospital into the virtual ward. It requires clinical protocols to be developed and agreed, etc., etc., etc. So what we're hearing is we've got to find alternative ways of bridging those gaps and other things to try and make sure that we've got as much capacity in place as we possibly can to avoid the gap of 91 beds, Gareth, that we currently face. And let's not kid ourselves. Even if we find a way to bridge the gap of 91 beds, such as winter and the peaks of activity that arise, that's going to be difficult to for us to manage. So Gareth, help us, reassure us, enthuse us about the plans we've got and the recommendations you have to enable us to be ameliorated. Did you want to come in at this point, Louise?
Yeah, thank you. So we've it's been set out the significant bed gap, and I just wanted to emphasise that whilst there is areas that have been identified with spaces, that is not the same as the provision of an acute bed, which a patient would need, and therefore would not be suitable for many people, and they are not an alternative. So I think we are identifying all aspects in this paper, but are very focused on the residual bed gap, and that was the nature of the discussions in the Chief Executive meeting, with the commitment of all partners working together to identify further actions that we can take individually and collectively to try and mitigate that gap. The risk is still significant in terms of that, so it's important we do so in order to then alleviate some of the long wait times, ambulance turnaround times and so forth. So that work is continuing, but I just wanted to make that point between the beds, the spaces, the residual bed gap. I think that's important to be clear.
Timings of meetings, because the board is before the Urgency and Emergency Care Board, which now means we've got the Urgency and Emergency Care Board after this. I think, is it next week or tomorrow? Okay. That doesn't quite give me as much time as I'd hoped for then. But I think we could task and could consider tasking the Urgency Emergency Care Board on behalf of this board to take away the comments from this discussion and it's easier to mobilise the Urgency Emergency Care Board at pace and additional meetings rather than a full board to have the delegated responsibility to work through, but then to come back, not with a full meeting, but to come back with an update to say, this is where the emergency care board's got to. I wouldn't want to lose, and so the board should ask for all partners to confirm to committing to the actions that both chief execs this morning and round the table have talked about, delivering on at pace, so that we can capture that and pick that up. And then the final bit is, and I don't know how to capture this in ease for the minutes or in terms of what it means around delivery, but Tina's point's spot on, that actually, you know, we mobilised to resettle circa 208, 220 odd people really quickly, provide healthcare at short notice within 2 weeks. So it's not that, because this is ongoing and relentless, and this is impacting on our staff. And I think it's important, actually, Chair, we thank all of our frontline staff and clinical staff and health and care staff who are delivering care in challenging situations. And I don't just mean in the acute trust here, I mean across the system. But we need to capture that bit that Tina said somewhere. But my proposal is urgent and emergency care board are tasked with delegated responsibility to drive this forward, and then to provide an update to the board.
And how would we receive that update? Do we mandate the Chief Executive's group to take decisions on our behalf, for example?
Well, I think you mandate the Urgent Emergency Care Board to take decisions on behalf of the board, and the Chief Execs will be going to the Urgent Emergency Care Board given the challenges of winter. I'm looking for
so the Chief Execs will be at the Urgent Emergency Care Board, is that what you mean?
And working with it. I mean, Louise chairs the Urgent Emergency Care Board.
So I know, and I suppose what I'm keen to have is that discussion with the Urgent and Emergency Care Board. That seems to me to be very important, very appropriate. We've got a suite of recommendations, ideas, proposals here that we need their advice about. I would like to suggest that their deliberations, their revision of the plan, should then be signed off by the Chief Executive's group on behalf of the whole board. Otherwise, we'll be talking about extraordinary meetings of the board and so forth, which, you know, frankly, we should try and avoid.
I'm comfortable with that.
Is the board happy with remitting the CEO group to do that on our behalf? Katrina and then Jonathan.
So the question then I would ask collectively of the board, accepting the fact I'm not, is that the patient level risk is, in terms of the risk to a patient, is that something that this board is happy to delegate, or does this board actually want to see and sign off on the level of risk that collectively we are willing to take in terms of patients as individuals? So that it's a question.
Yeah, Louise, I had imagined that this would be something that the Urgent and Emergency Care Board would be thinking about and taking into account. And as a suite of recommendations are developed and taken to the CEO's group, then we would seek advice from the CEO's group about risk and whether we think it's acceptable or not. Is that how you would see it, Louise?
Yeah, I mean, I think just reiterating, I definitely wouldn't be supporting that we accept the level of risk at this point. But note the work that we've done. We have more to do to mitigate the risk, which is where we've got. There is a role for the Urgent Emergency Care Board, fully agree, to try and lead and drive further actions to get to an improved position for patients and residents because of the potential impact of the winter pressures. I think there is a role for the Chief Executive Group also, who do need to be supportive and recommending approval of the winter plan. I concur with, I think, what you said in relation to Katrina's point, which was about the this board being then cited and supportive of the plan overall. So I think there's a role for each of those.
Is that reasonably clear? Are people broadly, Gareth, are you okay with that process?
I think that's spot on, absolutely.
Spot on, blimey. First of the day, thank you. All right.
Neil, sorry.
Oh, sorry, Meredith.
I'm very uncomfortable with this. Just the language feels wrong to me. So, for example, I don't think we'd want to approve something that we think looks like it's going to fail, or accept it because we can't do much else. It all feels really uncomfortable, to me anyway. And I think what I'd be looking to do is accept that everything had been done to make the situation as good as it could be. That's what I would want to be testing. Are we convinced assured that those responsible for delivering this plan have done everything possible to make it as good as it can be. That's my test question.
Thank you.
So I think that's a really helpful question for the UEC board and chief execs to have as the context to come back and say, okay, we need to answer that question.
Okay. Roger Dunshay's point is really important. We just cannot keep lurching through every year with this kind of difficulty coming up actually at the start of winter. We have got to find a way. We said it last year and we haven't managed to do it, although we had ideas about how it could be better for this winter. We have to find a way of beginning now the planning for next winter next year. I don't think anybody in this room would want to see us having to cobble together a plan, I don't mean cobble together, having to develop a plan at such late notice with winter already having befallen us. So Simon, Chief Executive and other colleagues, I'd ask you, in the new year, give us a programme of work that will show us how we're going to manage winter next year better. Okay, and let's bear in mind Tina's point about the spirit that's necessary, the spirit of collaboration that's necessary to get behind this. Harry, last word, and then I'm going to...
Yeah, can I just make a suggestion in terms of the way forward, which perhaps might give more visibility to this? Because I think what we're saying is we are delegating the authority to the Chief Exec Group to approve the plan, but we want them to flag risks to the board. And it could be the way to do that is to, when we look at the risk, create a risk register where the usual NHS form, and we ask for risks of a certain level to be brought back to the board. Then there's visibility at least, just trying to keep it front of mind.
Again, a helpful suggestion.
Let's bear that in mind as well. Okay, look, thank you very much indeed. Now, a number of you will no doubt have realised that we were due to have a 10-minute break at 3:45 after we'd discussed the local care programme and next steps in place development. I am in your hands. We could ask Patricia to lead that important discussion and then have a break, or we could have a break and if Patricia agrees, deal with the local care programme straight afterwards.
I think it's going to be very quick.
Sorry?
I think the local care piece is going to be reasonably quick.
So what would you like to do?
Yeah, do it now whilst we... Because I think it fits in...
It does, absolutely. I'm acutely conscious of that.
Yeah.
Let's do that then. Okay. So the break is to follow. So people behave themselves, they can look forward to a break in the near future.
So cross your legs and don't drink as much water for the next 5 minutes.
So as Patricia has said, the local care programme is germane in terms of winter planning. It's it's equally germane in terms of HTP that we heard about earlier. So Patricia, over to you. Help us with this important item.
Well, board members will remember that back in, might have been July, August's time, we had a session on local care in terms of the 5 programmes of work that have been agreed as part of the local care oversight, which include programmes 1 and 2, which were mainly around virtual ward and subacute care, and IDT, which has now moved rightly into the urgent care space. The other 2 key programmes of work being around neighbourhoods and the bed-based requirement, future bed-based requirement sits far more neatly within the place-based structure. And so we've been working on this with colleagues over the last few weeks to bring together the focus on place and in particular the kind of key areas that place are focused on, with the view that place should take on rightly a greater focus on neighbourhoods and the requirement for capacity out of hospital, which is an awful phrase. So it's bringing together the strengthening of place alongside the focus of local care, because local care is a huge programme which has a number of different programmes within it, and it's making sure that those programmes land in the right place. In essence, that's what we're proposing here within the recommendations. That will require And this fits neatly also with the good governance review within the ICB and also the development of the provider collaboratives to look at what is done within provider collaboratives, what is done at place and what is done at scale. And so in order to allow place, which is doing some fantastic work, we heard that earlier in the year as well, the reports back from both places, SHIP and TWIP, which is very much focused on local issues, that in order to move these programmes of work into place, we also therefore need to look at the constitution and the governance arrangements around place and strengthen that also. So really this paper is just the suggestion with the recommendations of us being able to get on with that and asking this board to allow us the mandate to do just that. Claire, given that you beautifully penned this paper, which is very clear, I don't know whether you want to add anything else in addition.
I don't think so. I think the offer there is to support the design, so the board gives the mandate for the next phase in the design. And I think we've heard around the hospital transformation programme and some of the winter challenges. If we're going to improve on next year, then this piece of work is hugely important around getting the local care and the place piece right. So it's really that mandate to, at pace, do the design work with our two places, too many places in one sentence, but yeah, thank you.
And what was quite interesting in the winter plan was the complete silence around primary care and the primary care focus, and in order for primary care to do more in terms of access, because that is a huge element in terms of prevention of conveyance to the acute trust, then actually having the systems and processes in place at neighbourhood to support primary care is going to be hugely important.
Thank you, Patricia. Thank you, Claire. Let me ask David and Andy, how do you feel about this paper and the suite of recommendations that we have?
I guess the only thing I reserve is the devil's in the detail, really, in terms of how that will be managed from a local perspective. The principle of it is sound, but if there's accountability and delivery, then resources need to come with it, and integration has to follow that as well.
It's a reasonable point. It's hard to disagree with that. Andy, did you want to add anything?
Yeah, I think much the same, really. It's just about who's involved in that and making sure that we've got the broadest kind of remit so we get the full advantage of the resources available in place, per se. Did you see my picture?
Nigel.
If I may, and I wholeheartedly support the direction of travel, I think certainly on recommendation 3, I think whilst place is important, and Patricia mentioned it, provider collaboration is also a vehicle amongst the delivery of this work. And we've heard and we know that within our provider collaborative, which has already started meeting, and we are taking forward some of those initial priorities within urgent emergency care, particularly with what SAF and Shropshire are already doing together, and we heard a bit about that from what Gareth was briefing. I think the second bit is, when I mentioned provider collaboration, whilst I know the 4 NHS trusts are absolutely pushing on work, there is collaboration that organisations are doing outside of the borders, which has real benefit. And, for example, if you take MPUFT, who are taking a lead role in mental health LD&A, that is a collaborative with a whole range of different partners, including local authorities and voluntary community sector. And also we've already started, and Julian and I have had a conversation as well, as I have with others, about how do we make sure, and particularly perhaps under the place partnerships and the integrated neighbourhood working, how primary care is a real vital partner, and I know that, you know, through the work that Claire Parker and others have done, they absolutely are. Thank you.
Thank you, Meredith.
Thanks very much. Just to pick up Nigel's point, I always argue actually the biggest provider in this, certainly in the neighbourhood context, is the voluntary community sector, so I want to make sure they're part of that provider collaborative in whichever way we describe that. The other thing is, I hope this doesn't sound critical, and Patricia used the word huge in a very huge way several times in your presentation, because it is huge. It's also really slow, and I just worry that we keep getting to points where we're being asked for decisions about governance and the kind of the architecture. And I think we're spending all this time doing governance and architecture and all that kind of stuff, but very little's happening in terms of delivery. Forgive me, okay, I know loads is happening, but I just wanted to make sure that it was running really quickly, especially as we've been hearing the presentation about HTP forging into the future, and I want to make sure that both strands are in tandem.
Thank you. Claire, did you want to respond to Meredith's point?
Yeah, I think it's a fair point. We don't have the same resource assigned to the local care programme that HCP does. And also that's been going for a long time, even before me. So I think the assurance that I'd like to give you, Meredith, is that the work is going on, whether we've got the governance right. And actually, some of the integrated neighbourhood teamwork, which is being allowed to develop what I call the team of teams between the partners, the voluntary sector, the local authority, is really starting to bear fruit and kind of a snowball effect, because they're being enabled to work out where the duplication and where the gaps are in their local communities. Now, we need to start and help garner all of that enthusiasm, energy, and make sure that it's delivering the outcomes that we want in the right place. But that is happening at the same time as we are trying to put some structure and governance around it to support the joint forward planning and then all the other parts of person-centred care and the hospital transformation programme. So it just feels like this is the mandate to take it forward, to bring everything together, including the governance, the new structure around the ICB and what that delivers, provider collaboratives and the local care programme. So it's a big moment in time, I think, but there is still work going on.
Thank you for the question, Meredith, and also the response, Claire. Can I just make a couple of comments about that? I'm sure I remember, that when we discussed this issue in a board development session, we noted the disparity of resource for HTP and for this programme, and we said this programme should be receiving a reasonable amount of resource. I don't think we said precisely how much, but we said, bearing in mind it's crucially important. It's one of the two huge cornerstones of our strategy for the future. So I don't know where the responsibility lies for sorting out a proper resourcing for the programme, but I thought, Gareth, it was something that you were looking into for us. And I'm not looking for a response now. I just put on the table again the requirement to make sure that it's adequately resourced, because it is a big ticket item. The other point I just wanted to echo, I mean, I thought this paper was very helpful, but I did get the kind of, I suppose, a shudder that Meredith has articulated, if you can articulate a shudder, that I don't want to be sitting around this table at the end of March talking about governance again, although we might be signing things off. It'd be great to actually see some core programme targets and activity plans, if you like, so we can have the confidence that we all need things are beginning to happen. And it's great to hear that in some neighbourhoods things are beginning to happen. Maybe it's me. I'm not personally cited on that. Maybe we should be sharing that more broadly so we can all see what's actually happening. Now, Julian, I think you were next.
Thank you. I think a lot of what I was going to say has been said. I mean, this to me appears to be a plan for a plan again. So, I'm not sure. As you said, there needs to be some more deliverables on what we're expecting to achieve and the outcomes. I don't really understand the bit about resources in 5.27528, which I think we've just touched upon, where we're saying that there isn't enough resources to run the programmes, we need more resources, and I think you've just said about how that was going to be looked at. But the other really big issue for me is that, yes, clearly we want to improve a lot of things, do more things in the community, the primary care access, but there doesn't be any plan in here to identify how we're going to get the resources to deliver the plans. And that truly worries me, that we're thinking about developing a plan where we haven't identified where we will get the money to pay for any new programmes of work that will come out of this. And presumably that will be through deprioritising and decommissioning other work that we're doing because there is no new money. And I wonder, where does that fit in? Because that's not even mentioned in this sort of paper.
Well, it's an issue close to my heart, and Simon and Claire Skidmore are probably sick to death of me asking about this, but as we think about strategic financial planning, this is the kind of thing that where we need to be having a debate about the financial implications and benefits of this kind of programme, how we're going to resource and what we think the impact might be. So Claire, help us, just in terms of a process for starting to get into this, can you help us?
Well, I think there's already process in place to a point. So part of the consideration that we're going through at the moment about ICB 3.0 and what that looks like into the new year very much needs to take into account what the wider system needs to look like as well. So we can't do that piece of thinking in isolation without looking at the totality of the operating model. We know that we've got a time limit on the resources we've had through the recovery support programme, so that's a known position at the moment. So we're maximising the use of what we've got in this financial year, and certainly with the likes of Claire coming into this space and Gemma, who's my strategic commissioning director, we're starting to bring resource around the programme. As we then build that, we need to better map, model exactly what we need, and then where those skills are either within the system or where we need to bring them in from outside because we don't have them at the moment. So there's parallel thinking going on. Some is the work already to look at the operating model more broadly, the people we've got, where we put them, and in part that started to move and we started to corral around the programme, and then that will develop over time. And yes, absolutely, we're going to have some difficult decisions about what might we not do if this is the priority, which we're all saying it is.
Yeah, and I think that's the important point. I mean, the programme, cost resourcing, I'm sure we'll come up with something. I don't know what, and I'm not sure what the source is. What's much more intriguing and challenging is how to shift some of the £1 billion per annum we spend on services and think about how we redirect some of that to support these kind of initiatives. And that's the discussion, I think, which we're yearning for, because it's hard, but it needs to start, and everybody needs to buy into it and understand what the consequences and the benefits are.
Can I just follow up on that? My problem with some of this is that it's like going shopping. You need to know what your budget is. So I'm sure the local care programme can come up with a whole long list of wonderful projects to do. But if in fact our budget will only account for 10% of what's being planned, shouldn't we have to start off with saying, this is the resource we've got, develop your programmes and prioritise them against this resource, and then work out what we want to deliver?
I think if we start with this is the resource we've got, we constrain our thinking. Yeah. We need to look at what's the resource we need, and then we work between that and what we've got.
And to be fair, there has been, with support from the ICB, the separation of the sort of virtual ward, subacute care, which is being absorbed into the urgent care, supported by the urgent care resource, because that's becoming business as usual, which has meant that the 2.2 whole-time equivalents funded through RSP are being focused now, mobilised to focus particularly on place, neighbourhoods and the wider issue. That still isn't enough, but it's also how we're wrapping around support from Claire, other sections of your team, Claire, also. And there will be more that's needed, but that's part and parcel of this design piece of work that Claire Parker was talking about with the local authorities, because there are resources across the system that can enable and support this. There will be some technical pieces of work where I think we will need additionality and to buy in services to move us on to the next stage. But this is the whole purpose for this paper and the design work, is to look at moving the resource that we've got for local care from virtual ward and other aspects onto this to give it an initial focus, so that we can move to the next stage.
Thank you. And Ian, last word to you, and I'm going to move us on.
Thank you, Chair. I think the plans always sounds good. The concern I have is about genuine integration. We do have a collective responsibility as providers to work collaboratively to move the agenda forward. But I think how we do integration do need a serious focus in the local care programme. most recently, Nick has designed a chronic disease management strategy. I think that's a good place to start in the local care program and how we drive forward integration.
Okay, thank you. Point noted.
Let's finish off with it in a saying. So I've mentioned the need for the last few board meetings for a long-term conditions strategy. It's not I've decided, I'm part of the population health management group, which has been working on it. And we've had two conversations slightly separate. One is how we pay for the management support to do this. The other is how we actually pay to care for our residents. And so much of what a lot of us imagine local care to be is around those patients who are currently being cared for in secondary care, for instance, whether through planned or emergency admissions, would that money be better off being spent in a more preventative, and I don't mean public health end of the spectrum of primary prevention, but I mean tertiary prevention, where we know patients have mild or moderate disease and stop it getting worse. And the focus currently, our next discussion we're having in a population health management group in a couple of weeks' time, will be particularly around those patients we know who have 2 or more long-term conditions who ended up having hospital admissions. I think that's where the financial saving in terms of spending our money differently. I think that's key to, and that can't be done in a one-year planning cycle. Unlike primary prevention, which takes 10 years to filter through, we could potentially do something really positive in a 2 or 3 year planning cycle.
I couldn't agree with you more, and there's a sort of a hint of that in the paper about proactive care and so forth, which plays into that area. Okay, so here's my summary. Thank you for the paper. There's some important work which is in train. We're promised actions by the end of Q4 in the round, as it were. Meanwhile, we're very keen to see something to describe delivery priorities and some timelines that we can actually look at and feel comfortable represents real change on the ground. We need to look at, and this is the second time we've said this, the resourcing for the programme, which is not promising the earth, but just begging the question about whether there is adequate direct, indirect support for the programme moving forward. I think we're hearing, the paper's very clear, there are 2 paragraphs that raises questions about that. We should bear that in mind. And the final point, which I think is so important, is this strategic financing question and how we begin to move the oil tanker away from traditional spends based on hospital care, for example, and begin to start a plan that directly reroutes resource into place and into neighbourhoods. And that will take longer, take some time. I think Nick makes a good point. We can start to make a start on that, but we need your help with that, Claire. Okay. Now, Patricia, you boldly forecast that this wouldn't take long, and you made some comments about people's toileting habits. Would people appreciate a 5-minute break? And now we're going to...
Can we be strict to the 5 minutes, Chair?
Well, I certainly can. Can you?
Yes.
Okay, good. 5 minutes. Thank you very much indeed.
seen the team.
So what needs to happen tonight for you to qualify?
A miracle.
Yeah. I don't pay any attention to this.
It's about, we have to win.
We've
never won there.
And do you need other results to go in your direction?
If we win.
You'll win tonight. I tell you, you'll win tonight.
It's got to be Bayern Munich at home then.
Thank you, everybody. Could you give Louise?
Yeah.
Okay, I'm going to start again, and the next item on the agenda is the System Board Assurance Framework. Alison Smith, over to you.
Thank you, Chair. I will keep this very short. I assume that everybody's read the report. So we're representing the System Board Assurance Framework to the Board today with the updates and changes to align the System Board Assurance Framework to the new objectives outlined in our joint forward plan. And just to give assurance to the Board that the System Board Assurance Framework and the Strategic Operational Risk Register that sits below it have started now to be shared with the ICB committees so that assurance can be taken through those committees on behalf of the Board. Happy to take any questions on the process, and I'm sure colleagues around the table would be happy to answer questions on the content for the risks specifically.
Any comments that people wish to raise? Simon, do you want to add anything?
Alison's got it covered, Chair.
So we...
Press on, we'll be sorted, Chair.
I know. So we approve the paper, the recommendations, and we move on from there. Yep, thank you very much indeed. The next item is the Integrated Care System Performance Report, for which it would be helpful if Patricia and Louise were present. Any sign of them?
They're just trying to cope with the world's slowest coffee machine in the moment.
Is Patricia nearby?
She was literally...
She stood next to the coffee
She was right behind me.
Right, okay. We'll try and get Patricia to join us as quickly as possible. But meanwhile, Claire, begin the presentation of the report, please.
Thank you. I'm going to take the report as read and just pull out some key highlights that I think are pertinent for Board to be cited on and actually are very relevant given the conversations that we've been having today. So in summary, we continue to have two significant performance pressures as a system, those being urgent and emergency care and finance. From a finance perspective, first of all, we have our month 7 results within the pack, which show that as at month 7, we had accumulated an £89 million deficit, which is 44.5 million away from the deficit plan that we had set. That was to enable us to meet a trajectory of a forecast deficit position of 57 million, and Board don't need to do a lot of intensive maths to work through the fact that that is not going to be possible to achieve. We cite a risk in the paper to that to the 57 million deficit plan, somewhere in the region of £92 million. Obviously, that is far in excess of where we would like to be, and there is significant work continuing and has been continuing for a while now to work on what we can to reduce that. Since the last Board and over the last few weeks, there have been now some national communications, so not just to our system but to all systems across the country, about the efforts that are expected for us to return to our planned positions, and those conversations with both the regional and national team are very live at the moment. So we referenced earlier
the private board session that we had last week and some of the conversations that we had there, they're continuing at the moment. So we don't have a formal position that's either signed off by this board or regional or national colleagues yet, but we have a follow-up meeting with the national team this time next week. I'll just do some headlines from performance and then I'll pause, Neil, to take questions. It's very easy to just pick out the negative headlines from this report. We talk about a lot of things for this system that challenge us and that are proving difficult, but actually there are some really good news stories in here that we must not lose sight of. 3 things to highlight in particular. First of all is that our new CDC, our diagnostic centre, has gone live. That was back in early October. We've had some really positive feedback from patients and staff, so that's fabulous in terms of that mobilisation and the benefits that that will bring in terms of diagnostics out in the community. With regard to our faster diagnostic standard, for the first time we're now at and actually ahead of our trajectory. Again, a really positive message and so important because it helps us maintain the delivery of our cancer performance, which has to be something that we keep our focus on as system partners. And then the third positive is around fit testing. It's taken a while to get in and to have that up and running, but actually we're now one of the best in the region in terms of our performance standards, and we're consistently in the 75 to 80% range. So again, testament to the hard work that's going in there. We're also seeing some slow but steady and continued improvement in mental health. Still some trajectories to rework around talking therapies, but in the main, we're seeing some traction and some progress, which we really do need to build on and do more with over the coming months. Unfortunately, I do then have to highlight the challenges because they're not going away, and particularly around that urgent and emergency care pressure, which we've talked about quite a bit already today. I think we mustn't lose sight of the really good work that we've been doing on our elective waiting times, and particularly looking at the pressures that we've got there and trying to protect that activity in spite of the challenges and issues that we have with urgent and emergency care. I do need to stress the need that our plan for elective for the remainder of the year is so important, not just for our patients, which of course is the key driver for what we're doing, but also actually because we have quite a large amount of additional income that's tied to that and will help us to achieve our financial plan. And then just to finish off really in terms of urgent and emergency care, we know that patients in some circumstances are waiting a long time, both on ambulances and once they get into our ED departments. We did see some improvements in Q1, but we have seen that deterioration over Q2 and Q3, which is driving a lot of the issues that we've talked about today. We know that the improvement programmes for urgent and emergency care are looking to refocus on that, and Louise, through the Urgent and Emergency Care Board, there's a lot of energy going into what we can do there, and I'm not going to repeat all the conversation we've had earlier about the bed model and other things. So we have to keep our focus on efficiency, productivity, doing the best we can in terms of building a sustainable workforce in order to help us really achieve some of those targets. I'll pause there, but I'm happy to pick up questions or seek support from colleagues who are closer to some of the detail than I am.
Thank you very much indeed, Claire. So some good news stories, some improvements, and you're right to make sure that they're drawn to our attention, Claire. Thank you for that. But some significant challenges, and we've talked about urgent and emergency care in the context of winter, and I'm not sure I had in mind that we should go over that again, but there may be questions that people want to raise about that, and I'll leave that to you. Finance. I'm going to ask Simon just to say a word or two about the system finance position and your take, Simon, in terms of that which we're required to do for the 6th of December and the NHSE debates that we're currently having. Do you want to start on that? And then I'll ask others for comments.
Yeah, so I mean, I think Claire set some of this out. We are in the process of responding to the national letter that came out from the National Director of Finance on the 8th. Well, it came out from Chief Nurse, Chief Operating Officer and Finance Director on the 8th of November. That made a request for all systems and all NHS statutory organisations to review current expenditure plans and delivery plans through to the rest of this financial year. There are a number of clear asks that then came out in additional operating guidance. As a system, we've been working very closely with national colleagues and with regional colleagues to work through that process. We have been, from an ICB perspective, we have significantly improved our position, but not without risk, and have set that out to the national team and articulated what that looks like. Our providers have done similarly and have been tasked with reviewing their positions to say what will it take to get back to plan and what does that look like. We continue to work through that with each of our providers. Just to be clear for the board that MPUFT are not part of this because they're in the Staffordshire and Stoke-on-Trent system, so this is South, Robert Jones and Shropcom. The system was also allocated a small amount of additional funding to be allocated as per an agreed approach with the system. We're still working through that process, but to be clear, it was a national 800 million and our figure won't cover all of the asks that we've currently got against that, although it does improve the total system position. We're under significant scrutiny. All finance and ops teams are working really hard on this, and there's a lot of template submissions, a lot of responses, and a lot of work that's then required to produce the templates in the first place, and that's having an impact on people. But as we currently sit here, we are not compliant with the national ask of where they would want us to get to, and we have a further number of escalation meetings to work through that. We are showing some small improvements in a number of areas, but there is an ongoing focus and an ongoing work programme at pace to deliver that. To be really clear, chief execs have been very close to this, as have finance directors, but it remains very challenging.
Thank you. Let me throw it open for any questions, comments that people wish to raise. Tina?
It's just a comment really, and I think it relates to our previous conversation about the pressure in the system. It's really concerning the number of patients who've acquired C. difficile. The trend's going up and up, and I think that is often symptomatic of the sorts of pressures that we're seeing in the system. So I think that gives us even more urgency to come up with some answers for the winter plan.
Thank you. Let me just gather the comments and then ask people to respond. Julian, Roger, you're next.
Yeah, just regarding the financial predicament we face, overspends are usually driven by three things, one of which you're underfunded, two, your unit costs are high, or thirdly, you're outperforming. And from a non-exec perspective, it's very difficult to understand where we fit in that scenario. Which is leading our cost? Is it we underfunded? Are we outperforming, or are unit costs high? And I would ask for future board meetings that we begin to drill down into particularly the unit cost aspects of our work. Because at the moment it's very difficult to understand, are we an efficient ICS or are we cost outliers? And at the moment I just don't know.
Yeah, it's interesting, isn't it? Because Claire, the so-called reference cost, which is a national mechanism for calculating our cost base against the other part of the NHS, suggests that we are at 88% or thereabouts.
Something like that.
Something like that. Now, this is imprecise, as you know. So you might argue that our cost base is low. You might argue it's too low. However, you might also argue the fact that we were allowed a significant deficit this year was in recognition of the fact that our cost base is low. So we seem to be being compensated by that currently. But I think your point's a good one and merits further inquiry.
Yeah, absolutely. I mean, we've had some of this conversation with colleagues from the regional and national team, it's very difficult to make a case that we're outperforming that's driving the spend, because actually our performance targets, in the main, not all, as we've heard, but would suggest otherwise. We do have quite a focus on productivity and efficiency, as you'd expect, Roger, which would help to then set out some of those other areas that you talk about. And that's something that through Finance Committee we're starting to develop how we do more with that. Certainly we can look to see how we categorise the drivers of our spend in terms of the presentation of what we've got, but just as an example really in terms of your cost base positioning, one of the reasons for the ICB, for example, that we've drifted beyond plan is that whilst we planned for a certain level of inflationary uplift in CHC, and actually for our existing contracts, we were able to manage those contracts to that level of inflationary uplift. We're beholden to the market for new packages, and those prices are coming in materially higher than what we had planned or envisaged. So to give a sense of scale, we put in a 5% pricing uplift, whereas at the last look, we haven't rerun the numbers this month yet, but at the last look, some of the new packages were averaging around a 19% uplift compared to those similar packages last year. So market pressures is definitely in there, but there's other routes to describe that as well that we can take a look at.
Thank you. Was it Julian? You two seem to work in tandem. One of you raises a hand and followed by the other, and vice versa.
It's like one of those old-fashioned videos.
It's all rehearsed before.
My question is very similar to my previous question. I mean, my problem is probably in my heart of hearts, I want to spend more money on healthcare and social care rather than less, and obviously that's not really in line with what we signed up to onto the ICB board, because we're promising to spend less and live within our budget. But the reason I say I want to spend more is I'd like to see more spent in the community, and I wonder if I was in NHS England shoes, I'd like to see us spend less and then not spend that money that we're saving on other things, but keep that money to offset our deficits. I wonder whether we need to have a workshop or some work about how we work creatively to actually, at the same time as reducing our deficit, also increase our spend in other areas, and how we actually can do that. Because I think if we have too much of a spotlight on us, and it's England may say, if you're going to save £10 million over here, you need to give that back to us, not spend £6 million of it over there. And I think it's how do we do that, and how do we do it in an imaginative way that it allows us to improve. Because I think if I do sit next to Louise every time with a bit of trepidation, thinking that I'm not sure how staff would like it if we took £50 million off them. Probably it wouldn't work, and we'd have a bigger problem in our hospitals and our system rather than less of a problem. So I find it very uneasy to think we should be spending less, but I appreciate we need to do that. But it's how we can be creative to spend more in other areas.
Yeah.
Is that a bad thing to ask public?
Yeah. I think the challenge is really fair in that space, Julian, actually, and Louise can speak for herself. But if you took £1 million off and at the same time said didn't have the escalation capacity open, was delivering care in a different way, she'd probably clap you on the back and say, let's deliver care in a fundamentally different way, and it's not an issue in terms of moving £1 million around. The challenge, I think, the national team are absolutely in the space of saying, so what is your medium-term financial plan to right-size your system and to get to a sustainable clinical model of care where you articulate what that looks like? But they have challenged us to say you need to control your in-year expenditure and demonstrate that control and demonstrate that you can deliver an improvement, whilst at the same time we get into a really clear conversation about that medium-term sustainability plan. So they have asked that question as well, because we've talked about the challenges of and the importance of delivery of a hospital transformation programme, the local care programme, the rurality challenges, the running two sites with 2 EDs, and the hidden costs that get built into that. So part of the narrative and part of the conversation has been absolutely about that and in that discussion. So I think the question's fair, and we're in it. It's creating the capacity to do both.
Okay. Dave?
We've done a lot of work at that, and we have to remember that actually a lot of the planning assumptions that are set out by the NHS have are actually not reality, are not differ quite some way from reality. Their inflation assumptions are way out. We looked at, if you look at drugs, you look at medical devices, you look at estates, their inflation, the real inflation rates in those areas are running really, really high. Plus also, we still have, in the acute sector, we still have very significant issues around non-criteria to reside, which means that we're opening up very, very expensive surge capacity that is staffed at premium rates in terms of agency. There are a number of things, and the thing I get concerned about is that these are real challenges, and I think it's very difficult. You can go through these numbers. It's very difficult to isolate inefficiencies that are driving cost overspend. They are realities that NHS England is absolutely refusing to accept on the one hand, and B, cannot be solved by individual organisations. And I think one of the things that we need to do is actually look at some of these key issues that need to be addressed on a system-wide basis.
So I think the second point, absolutely, I agree, and I think that's the conversation we've been having in terms of what do we mean by integration, and how does that, how will the provider collaboration and other proposals drive out some of those inefficiencies in terms of how the pathways of care are delivered. That needs to be clinically owned. I think Finance Committee have had some of the conversation around the drivers of the deficit and the variance from plan. But clearly, from Roger's question and from yours, Dave, then we can do more, because we can clearly articulate, as can our providers, which elements are linked to inflationary pressures that are outside of control, which are activity driven, which are planning variance and assumptions that were made. So all that information is there because we've been going through that line by line, as well as what investments have we made, what have we pulled back in terms of those investments, where's that money gone and what's that delivering. Can we do more? I think we can always do more and we can always be clearer in that space. But I think we can answer a lot of what you and Roger have said. I think we need to get better at showing that.
Yeah, I think so. I think we need to push back, and I think we need to push back. So I think this is important when it's factored into the 24-25 planning round as well, that we do push back on some of these assumptions. And one of the things that is also clear is that activity increases as well are significantly understated in national plans, and we just need to be cognizant of this and understand how these realities are going to be reflected in a plan, rather than assuming that these don't exist.
Yeah, you make some really important points, and I wouldn't disagree with any of the principles that lay behind them. The reality is, though, we are tasked with living within the amount of money that's allocated to us, notwithstanding the misalignment, if you like, of planning assumptions and the realities. Inflation's a really good example. And when I look across the spectrum of financial performance and the areas where the pressures lie, it seems to me there are some areas which is very hard to imagine how we can control, but there are others which I'm personally very, very, very clear about we ought to be able to grip harder and be able to control it. It's making sure that on the latter, we're able to demonstrate we're doing everything we need to do, and I don't think we're doing that yet. And when you can do that, as you know, when you can do that, you're in a much stronger position to argue about the difficulties of the funding allocation or inflation awards and so forth. But when you're faced with some basic operational issues that we're not managing as well as we could do, and the financial pressures they create, that has to be the priority for us, it seems to me. And I'm sure you'd agree with that.
Yeah, no, I agree. I just, for me though, I think it's a question of understanding what the balancing is, because frankly, you can return to break even tomorrow if you wanted to, but that has such an enormous amount of knock-on effects in terms of patient safety and quality of performance. That has to be borne in mind. But we also need to, I think, question some of the things. I mean, for example, things like establishment numbers, etc., and safety levels at operating level. I think we need to get into some of those things as well.
Yeah, and I mean, to be fair, we do. And you mentioned the workforce issues. If you look at the performance report, that as a system, We seem to be employing about 310 full-time equivalents more than planned, which means we're employing as a system about 310 more people than we have budgeted for. That's the kind of thing that we really have to be able to assert more control and manage better, or at least be able to justify it and explain the rationale behind that. Because without that kind of strong focus on performance, and any other arguments, more elegant arguments we have about funding futures, are difficult to put forward.
Yeah.
It comes back to, well, sort your house out first, and then we might listen to you. I put it crudely, but that's the reality.
Yeah.
Ian?
Just a quick one from me. The issue for me is all the things that we're trying to do takes time for results, and likewise with the financial element of it. In the past, we looked to invest to save. We can no longer do that anymore. The dilemma will be about long-term, that we're going to focus on integration to deliver us the savings. But in the past, we're able to use innovation to do that. So I think the focus should not only just be on integration, but also on innovation.
Thank you. Meredith, did you want to comment on that, or did you have another point you wanted?
More general, Neil, more general. I'd like to say a big thank you to our partners working with Simon and Claire to deal with what must be horrible stress and drain and burden. And so I'd like to say a big thank you and for all the work you've done. Can you just keep on trying that little bit more in the way that Neil's described? I thought Dave's comments are really helpful and important to remind us that actually it's a very, very difficult job that you've got at the moment, and probably unfair, but I did just want to say thank you very much indeed, and also to pick up Claire's point about our gains, our successes, because we've already forgotten about them, and I just want to make sure we make them maximise those, because they didn't come out of thin air. They came out of a lot of hard work by a lot of people as well. So, sorry, Neil, I just wanted to put that on my record.
No, I thank you for those comments. I think we'd all echo them. The predicament within which we find ourselves is not because people don't care. It's not because people aren't trying hard to find solutions. It's a whole panoply of issues. But we shouldn't underestimate the time, the commitment, and the hard work that people are putting in to try and turn this corner. But there's an awful lot more still to be done, as we have said. I didn't want to lose sight of the C. diff point that you raised, Tina. It is an indicator of stress. I agree entirely. And I just wanted to, I guess, Nick, Alison, just ask you to hang on to that, have a look at it, and give us some advice about that through the appropriate committee in time.
Sorry, Neil, just to say it is already being looked at.
I thought it was, yeah.
IPC group for the system, who sees that, he will report into the Quality Performance Committee.
So moving on, if I may, some good stories, some good signs of progress, good developments, and Meredith, Claire, absolutely right. We mustn't lose sight of those. Urgent and emergency care. We're at a crucial time, as we discussed earlier, as we move into winter. We look forward to further advice about how we might improve the capacity to, in turn, improve patient experience and performance. In terms of finance, I just ask everybody to continue to bear down on the areas for which you have responsibilities and, more importantly, direct control, and see what can be done. I mean, we're not going to find a means of delivering our plan or anything remotely near that, but being able to show that we can get into this concept of positive run rate as a system and by organisation is really important in terms of our confidence, our own self-confidence, but confidence with regulators that we're beginning to turn the corner. And we've had various discussions with colleagues about that. I think that's, Claire, would you agree, a really important challenge? And if we can pull that off, even though it might not make a massive difference to the bottom line, it will show that there are things that can be done to improve things in the longer term, well, the medium term.
Yeah, that exit run rate into next year is crucial, because the more the opening position worsens, the harder the job we've got next year, and we know it's already going to be tough.
Okay, thank you very much indeed. There's nothing like a good discussion about governance handbooks to lighten the spirit and improve morale. So let's move on to the next item. Amendments to the governance handbook. It says Simon Whitehouse. Tickle our fancy.
My Director of Governance chose perfect timing to step out, so I'll make this really quick on that basis.
Good.
Paper as read, the first two recommendations are purely about making sure we get the scheme of the reservation delegation in the right place. I'd like to withdraw the third one, which is around the addition of a further subcommittee. There's further work to do in that space. So I'm asking the board to approve the first two, which is about terms of reference and scheme of delegation, and I'm withdrawing the third, Chair.
Okay. Everybody happy with that? That's not to say it's unimportant and it's not urgent. It is both those, but we need to find better ways of being able to deal with this.
And I think the paper's clearly set out what the changes are, so I don't need to go through them on a line-by-line basis.
Yeah.
Everybody happy with that?
Yeah.
That's the most entertaining discussion about governance I've heard for such a long time. Thank you very much indeed. System level primary care access improvement plan. Gareth.
Thank you, Chair. I'm very conscious of time, but there's a couple of points that I would just like to highlight as part of the paper. So included within the enclosures, and I think it's page 32 of the appendices, is the detailed primary care access recovery programme. Actually, I'm glad that this was on the agenda because, David, it allows me to now answer the question that you asked me earlier on that I stumbled on. This document has been through a number of areas which allows us to have confidence that it's been through most partners, if not all partners. The paper summarises it's been through the System Operational Leads, SHIP and TWIP, and the Integrated Delivery Committee. It's also scheduled for Shropshire's Health Oversight Scrutiny Committee in January with a briefing this or next week. It's scheduled for the Joint Scrutiny Committee, but I haven't got a date on that yet just because of the scheduling of the agenda. So apologies for missing my lines earlier on, but hopefully that gives you a bit more confidence that this has been shared broadly. In terms of the content, the plan sets out the requirements for the recovery programme. There's a national context, but actually the real need is within the system. It sets out our ambition to improve access to general practice, maintain and improve patient satisfaction, and work to streamline care and advice. You will see within the document a huge amount of content, but it boils down to four pillars of work. The first is empowering our patients. The rollout of the NHS app, maximising self-referral and an increase of community pharmacy being at the heart of those. Implementing the modern general practice model, which really focuses more on improving digital telephony and online access, and building capacity in both workforce and estates. And then the final aspect of it is cutting bureaucracy. The plan sets out the detail in terms of the current position, what's underway and what will be delivered. But it's worth me underlining that this isn't a transformation programme that's going to fundamentally address the capacity shortfall we have in primary care, as with many other services. It is very much about making sure that the resources we currently have are deployed as effectively as they can. So what I don't want the board to be taking from this is that it's the fundamental answer to all of the primary care access issues that our colleagues sitting to my right feel on a much more visceral basis than I do. The final part of the document sets out a proposal. The paper was written, apologies, before the Primary Care Commissioning Committee, where we actually reined back on a slight change to governance. We are intending to set up a Primary Care Access Recovery Programme Board that will oversee this, but there's some developmental work that needs to take place at the Primary Care Committee, which is taking place on Friday the 1st of December, and I'll be able to report back the outcome of that at a later date.
Thank you very much indeed. There's two clear recommendations, is that right, in the paper? Julian, Ian, do you want to add anything at this point? Excuse me.
Not particularly. I mean, I think Gareth has highlighted the main issue. I think the paper itself does show the fact there's rising demand and rising number of appointments done in primary care and falling satisfaction. And I think it has set out the government's plans how to address that. I mean, I think that it's the detail and it's the delivery of the plan, and to see whether that translates into improved access. I do think as I flagged at previous meetings, I think that modern general practice is something that's increasingly done in practices, but I think there's mixed messages. It's high, there's some of the data I saw the other day, today, in one of the newspaper articles was highlighting the number of people who actually have to fill in a form for this EGP, implying that's a negative, whereas in fact that is actually the government's plan for primary care through model general practice. So I think there's a lot of explaining to the public about the rationale for changes, otherwise we will keep being pilloried for having less access to see GPs and seeing other allied professionals and less direct access in without having to go through triage, whereas that is the plan we're being asked to deliver. But it's as I said, the Primary Care Act plan is a reasonable reflection of, it is a good reflection of what we're doing locally.
You covered it.
Yeah, sorry. No, I agree with what Julian said so far. I mean, these are all great, but they're not going to be a silver bullet to some of the intrinsic limitations we have within the system, such as overall GP numbers. It hasn't increased significantly since 2015. Also, that has been somewhat offset by the PCN additional role reimbursement scheme. But because of the ongoing cost pressure, workforce is going to remain an issue, particularly if you look at the national picture. GP practices are not using locums anymore. They tend to just absorb the demand by themselves and not using locums. Some of the cost pressures are actually coming from NHS as well, because they promise staff a 6% pay rise, but only giving practice only 3.9%. And that's to the global sum and not actually funding the actual 6% increase. So that's going to be an issue locally too.
Okay, thank you, Nigel.
Just as a parallel, if I may, Chair, that one of the papers that we had at the ICB Strategy Committee very recently, beginning in November, was the strategy for GPs, and I appreciate primary care is more than GPs, but as Ian said, it's an important element, and I think we were struck that that was actually quite a really useful document that looked at both doctors in training as well as supporting those through a variety of different stages in their career, and was quite a well thought through strategy, which I'm sure Julian and Ian and across the PCNs will be really aware of. But I think it sits alongside, certainly in the medium to longer term, as well as obviously supporting the short term.
Okay, thank you. So I think, Gareth, what we're saying is, insofar as this goes, it's accepted, but there's much more to be done in terms of, for example, primary care staffing, supply and demand. And we just need to be sure, Nigel, that that work is in train within the strategy committee, PCC, or somewhere. Okay.
It's certainly absolutely being picked up within that primary care director working with the PCN.
That's really helpful. Thank you. Board committee reports. My suggestion is that on the basis that I'm sure everybody in this room has read every one of those reports syllable by syllable, that I need not go through them with each of you, inviting the chairs to speak to them. So, I was hoping to get a few more nods of support, just one or two cursory glances. And are the chairs happy for me simply to ask the board for any particular meeting, is there an issue that you want to raise? You okay with that, Roger? Any particular point?
Just one.
There's always somebody.
Sorry. Just very quickly, we now have a board assurance framework, which Alison and colleagues have been working on. I think what we would be looking from the audit committee, and I would also suggest the other audit committees across the system, is that we actually see evidence of it working. Thank you.
Yeah, and we covered that in a sense with the discussion we had earlier about how that's developing. Thank you very much indeed. Meredith, are there any particular points you want to raise? Thank you. Trevor has had to sign off some time ago. So I'm assuming that in terms of the Finance Committee and REMCOM, there aren't any burning issues, Claire, that he would have wanted to have raised with us?
Not that I'm aware of from the Finance Committee. I can't comment on REMCOM.
And Nigel, in terms of Strategy Committee and Cathy's absence, are there any other issues you want to draw to our attention?
Nothing further to add, Chair.
Okay, thank you. And Katrina, the System People Committee report, there's no report, so...
Due to meet next week.
Okay, thank you very much indeed. Nitty's not here. And Harry, the Integrated Delivery Committee?
We've covered everything. The only one point I would make, and it's more about the governance arrangements in the future, is that we discussed at length the issue of beds for the winter plan, but frankly we didn't have the right people there, so that's why today you're discussing it again. So if we can just think about that, otherwise take it off the agenda. If we can't actually make progress, there's no point in discussing it.
Okay, thank you. So I've not been notified of any of the business. The next meeting is scheduled for the 31st of January. There's an awful lot happening, and I'm not going to be proposing any kind of an extraordinary meeting before Christmas, but I dare say some of us might need to congregate on one or two issues between now and then. Let's just keep our options open about that, but we certainly wouldn't propose to call a full board meeting unless something absolutely extraordinary happens. Sam, is that okay?
That's absolutely fine, Chair.
Thank you all for your contributions. It's been a full-on meeting. We've covered a lot of ground, and we've talked about some really important developments and advancements, whilst at the same time reflecting on some of the challenges. And I've still got echoing in my mind Tina's comments. Remember how we coped with COVID. Just let's bear that in mind as we pull together over the next few weeks and months to deal with the winter pressures, financial pressures, and lots of other things as well. And I think we have some cause for optimism as we look forward because of the good things that are happening and our ability to work together more closely to make sure that the services we provide for people are as good as they possibly can be. Thank you all very much indeed.
Thank you, Chair.